brainstorm and let me know how I can make your day as useful as possible. But we are really excited, all kidding aside, to be here at Turf Valley. Just an advertisement. This is actually where we'll be doing our annual institute in October. So if you like this venue and you see that golf course, you're like, wow, I really want to hit something down the middle on, I think that's the 9th hole, then we'll be here in October, and we would love for you guys to be here as well. Good packed agenda today. We're going to be going through a lot of different technical matters as it relates to the HSCRC. We'll get to hear for the first time from the executive director, this executive director, which is great at our event. We're super excited to have him here. Seems like the temperature has come up in the room. It was 52 degrees when we got here this morning. So if we have over-adjusted, let me know. I don't think we paid for Wi-Fi. Sorry. Is that right, Holly? We don't have Wi-Fi. We didn't pay for Wi-Fi. Okay, got it. So we're taking all the bandwidth. We will be recording today's meeting, and you will get copies of the recording of today's meeting. So if you want to share this with your kids later on this weekend, things like that, you will have it available to you. So anyways, so just a couple things on the agenda that we're going to be talking about today. We're going to hear from the executive director of the HSCRC, as I mentioned. We'll also be hearing from the Maryland Hospital Association of what they're seeing in terms of priorities for the state and for the HSCRC. We're going to be talking about ED length of stay. I think that's a big topic for many of you, and you'll be able to hear what the HSCRC is thinking about that. I think, respectfully to the rest of the speakers, I'm really excited about the CRISP presentation because, I don't know, it was maybe 2 months or so ago, the CRISP team walked me through all of the analytics that they had available, and I was like, wow, does anybody know that these exist? And there's some really cool stuff. So they're going to walk through some of the things that are available to the hospitals to help them manage reimbursement, things that maybe you pay consultants for now that you might not need to pay consultants for anymore. So that's pretty cool stuff. Then we'll grab lunch. The annual filing, near and dear to my heart. We'll be getting an update on potential big changes coming to the annual filing. So hold on to your seats. I know you'll be excited for that. Alan and Kate will be talking about volume, and then we added some practical experience today to talk about patient experience. We've struggled as a state as it relates to experience measures for quite a long time. So brought in somebody today to talk about with practical experience around how to move the needle on patient experience. So I'm pretty excited about that. And then we'll wrap up with a conversation about EQIP and CTIs as well as a legislative update. So all that being said, caffeine is out in the hallway. We'll have coffee and water all day long, so get your fill. Grab breakfast if you haven't already, and don't feel like you can't get up during the presentation to refresh. Any questions? All right, let's get rocking and rolling. So I turned 40 in May, so like now I feel like I have to do this. When I look at my phone, I'm not quite as young as I used to be. So our first speaker today, John Crum, has more than 2 decades of experience in leading and evaluating innovative healthcare policies and programs, both in the public and the private sector. Dr. Crum, prior to taking the role at the HSCRC, was a managing principal in the Baltimore office of Health Management Associates, where he advised state governments, health plans, healthcare technology companies on a variety of finance and coverage policy matters. So please take a moment and give a round of applause and welcome John.
Thank you, James, and thanks everybody. And I know I've met a bunch of you in other HFMA events and so forth, but this is the first time that we've been at this HSCRC HFMA event. Really excited about the opportunity to come and have some great discussion and have some good collaboration as we talk through a bunch of issues here. Hey, I think it's really exciting that we're going to get some good discussion around patient experience. That's something that I've worked on in other settings and is a challenge. And hey, that's something that we have, I think, some real opportunity to make some strides on. So let me jump right in here. So we're going to have a lot of discussion today from folks on fairly technical aspects of the model. I wanted to make sure that, you know, for the folks who maybe are just a few months on the job, right, and who need a little bit of a warm-up, we start with just an overview of how we think about the model, right? So, of course, we've got, you know, the population-based revenue, global budgets at the center. This is a hospital-focused model today, right? And, you know, the way that I kind of have always thought about global budgets is that, you know, the goal here is to, you know, of course, maintain relatively high unit costs, particularly in the Medicaid and Medicare space, while reducing potentially avoidable utilization and shifting particularly low acuity care into lower cost settings, right? That's the core. That's a lot of what we spend our time on a daily basis. The second circle out, payment and delivery system reform. Obviously, right, we cannot transform the entire healthcare system without our post-acute, subacute, pre-acute, whatever you want to call it, settings, right, on board and rowing with us. So within the model, utilizing some of the savings to drive those partnerships. And then further out, Maryland communities. This is really our population health strategies, right? So making sure that we're getting good investments there. So I'm going to talk a little bit in two parts today, right? I'll spend a little bit of time kind of just updating, status update on the current model, where we're going next, what we're working on this year. But then I'm going to talk about the ahead model. And I'll come back to a version of this slide, right? Because I think when we think about the ahead model, there's opportunity really on all three of these levels, right? But I think the real promise of the ahead model is in those two outer spheres, right? We will work on global budgets. I think we need to refine and enhance. But on those outer two spheres, right, we've got a lot of opportunity to enlist new partners, right, get new alignment that doesn't exist today to drive greater impact, particularly on population health. So as we continue these conversations over time, I hope that our conversations kind of start to have more of that population health lens increasingly over time. So that'll be a test. If we're back here in a year and then back here in 2 years and we're talking more about our impact on population health, that's a win, right? Okay, so let's dive in to the current model. There we go. So this is essentially a little bit of a restatement of our last slide, right? So driving things in hospital population-based revenues, right? We've got 98% of hospital revenues within that model. That's something that we're gonna think about within the context of ahead. Is that appropriate, right? But I think it's it is certainly a win to have so much of the hospital revenue within that framework. And then, the other thing I'll note is the amount that is at risk, all payer revenue at risk for quality outcomes, I think that is a big part of the story here, right? And we can talk, we'll certainly talk a lot more about that later in the day. Health system collaboration, you know, I think MDPCP and EQUIP, they need to evolve, right? But they are big wins, and we should think about them as big wins in terms of the breadth, the scope, and the impact that they're driving. There's not much else out there on a national scale that works in this way, right? So we've got a lot of foundational pieces to build off of in that sphere, right? And then statewide reach. Again, some of our programs are in their infancy. We've got a lot of opportunity here to think about how we're driving impact in the community, impact in population health. And I would say a lot of our kind of immediate, the way that we're thinking about kind of immediate next steps is around, hey, how do we get a common framework here so that we can start aligning our efforts with kind of other parts, other disparate parts, siloed parts of the healthcare system, the public health system more broadly within the state, and then the parts of the state that are really working hard to meet social needs, right? How do we align all of these disparate efforts, right, going forward? So, one way to measure our progress here within the model is in essentially our report card, right, from CMS. These are the things that CMS evaluates us on year over year, and we're doing pretty well, right? So we are certainly meeting the first test up at the top, the annual Medicare total cost of care savings. That is a big test. That is what CMMI pays a lot of attention to, and we're doing fairly well by the tests set up in the model. Really across the board, you know, I will talk a little bit more about readmissions because I think this is one of the big, I think, wins of the model and something that we should all be kind of celebrating together. You know, and here, even on this one where we've had some, I would say, partial misses in the last couple years, even there, when we risk adjust, we hit those targets, right? So we've been successful as a state working together to meet the tests that CMS has laid out for us. But we need to think more broadly about the impact that we're driving, right? Because at the end of the day, what we're accountable for, right, is driving affordability and quality in healthcare delivery for Marylanders, right? So we've got to really think more broadly than are we successful against the CMS test, right? So when we look at what we've achieved, we have driven a lot of improvement, right, in the quality side of the equation, right? And, you know, I would, again, as we talk about ED length of stay, right, we can look to things like readmissions where, hey, we started this journey together in a really challenged, opportunity-rich, right, state in terms of our readmissions outcomes, right? We've been able to pivot that in a relatively short amount of time, right, with focused effort and partnership, right? So I think we've demonstrated success that when we, you know, put our mind to it, we can really move a lot of these quality outcomes, which is fantastic and I think really promising for the future. On the cost side, certainly this is where I think we're getting a lot of national attention, of course, in terms of driving cost savings, you know, from CMS. But I would also say this is really important for Marylanders, right? We are in a state, as all states, where, you know, people and their families are really stretched to afford healthcare, right? We are doing more together as a group here to drive affordability in healthcare than most other programs in the country, and it's something that we should be proud of. Now, we'll come back to these cost savings in a moment. But to put a finer point on what I just said, right, when we think about it, the fact that we're holding per capita hospital growth costs below state GSP is a huge deal. It's a huge deal because what we're saying is, look, we're holding ourselves to the same growth that, you know, our families are held to, right? You know, the same pressures, financial pressures that our families have, our neighbors have, right, in their own households. We're holding ourselves accountable to a similar level of growth, right? I think as we think about this from a policy perspective, this is kind of the gold standard, right? Now, let me pause here for a few moments, though, because I think there are some narratives underneath that we have, discussions underneath this that we have to talk about, right? One is, what does it mean to overshoot the target? What does it mean to overshoot a savings target, right? We have to make sure that we're not kind of thinking about infinite savings as the target, right? Because there's a cost to driving savings, right? So as we move forward and think about the next iteration of the model, this will be one of the important conversations that we have. It's like, what do we do to make sure that when we drive savings above target, essentially, which we've been able to consistently do, right? What are we doing to ensure that we're purposeful in what those savings go back to, right? Because we know that we're going to need to make investments to make those population health improvement strides that we've talked about, right? That will require investment, right? We know that hospitals as an industry across the country are facing intense financial pressures, right? So we need to make sure that we are purposeful in these savings. And I think that's a lot of our work together as we think about the next iteration of the model, right? I will say, though, that within the context of this model, right, I think one of the things that we should recognize, though, is that hospital balance sheets have fared pretty well under this model, right? So when we think about some of the things that we kind of look at and other folks around the country look at to assess that, you know, days cash on hand, better now than back in 2013, right? Debt to unrestricted net assets, right? Again, better now than it was back in 2013. Again, not discounting the intense financial pressures that exist today on hospitals, not discounting that COVID was a journey for all of us, right? So not discounting those things. I think when we look and compare to the counterfactual of both what exists in other states or kind of a universe where we don't have the smoothing effect of the model within COVID, right? All in all, I think there are some real positive aspects of the model for hospital finances. The other thing that I'll mention is that, you know, I know that as we close out this past calendar year, right, and we think about the rebound coming out of COVID and where we got to from a savings perspective, it's also important to note that some of that was driven by specific policy actions that will end, right, or have already ended. So some of that savings that existed in 2023 will not pull over to 2024. So it's something that we'll talk about more, hopefully throughout the day, but also as we talk about, you know, projections for 2024. But it's important to note that, right, that that we should not be looking at necessarily 2022 and 2023 as like steady state examples of, you know, where we are from a savings perspective or where we are from a financial performance perspective, right? So again, more to sift through as we get deeper into the AHEAD conversation. Health equity initiatives. So I think one of the things that when we think about the future of the model, we've made some strides with health equity improvement, right? Although sometimes it hasn't been centered on that, right? So I'll give you a couple examples. Inherently, the fact that HSCRC's policies support access to care in low-income communities because of how Medicare and Medicaid rates work within this model is beneficial to equity, right? But I think as we move forward, we have to be more, again, purposeful about tracking, well, what is the direct impact on equity? You know, can we do more? Is there, you know, can we do more targeted things to support access to care for low-income communities, right? So I think what we would say is that we have some good foundational elements building toward an equity-centered model. As we move forward, we've got to take the next step in terms of being really purposeful and planful about how we want to solve for disparities and equity challenges across the kind of continuum of care. So I'll talk a little bit more about that in a moment. And then just a couple other things that I just want to highlight, right? So again, as I mentioned, EQIP and MDPCP, we'll talk more about EQIP and CTIs later today. You know, I really, you know, want to highlight the potential that these programs have, right, in terms of transforming both the care that is delivered outside of hospitals as well as the care that is delivered inside of hospitals. So we'll talk more about that, but I think it is something that Maryland sometimes does. It's not well understood outside of the state sometimes how these programs work, but they're really impactful, especially when we look at kind of the broader CMS program landscape, right? These are driving more impacts at bigger scale than most any other type of program. So let me, and then revenue for reform, really important initiative. It's in its infancy, right? So this will be a focus of policy development for us going forward. We'll talk more about that later today. So I want to mention these. I think we will be publishing a policy calendar at our next commission meeting next week. These are some of the policy priorities that we worked with our commissioners to establish. These will go on the calendar shortly. A lot of it is driven by feedback from you all, right? So we are hearing, right, that we need to, for example, review our volume policies. We agree with that. We're going to do that work. Please join us in doing that, right? And then there are others that are on here, partially because we need to ready ourselves for the AHEAD model, and also because we have opportunity, right, to drive impact. So equity measures, right? That's really going to be foundational work for us as we seek to drive greater equity impact in alignment with MDH and other state partners, right? accelerating our quality improvement programs, right? We've made some good strides there. We have some opportunities. So I think we've gotten a good balance of priorities. These are our priorities for the current model. There will be a huge amount of work over the next year and a half, 2 years, focused on the ahead model that's not included in this. And some of this will be leveraged for that work, but I just want to make sure that folks understand there's this, and then there's like 50% more just focused on the ahead model, right? So this will be a busy couple years. Okay, speaking of the ahead model, let me spend a couple minutes here on the ahead model, and then I'll make sure that we have some time for questions here. So this is our kind of global high-level 30,000-foot vision here. Again, equity-centered, right? I'll come back to this in a moment, but I think the important thing to note here is that equity and population health are really the underlying kind of driver, right, for all of our work here. And then the other thing to note is that while hospitals are at the center of the model and will continue to be at the center of the model, we really have to be thinking about the impact that we're driving across the care continuum, right? So more to come on this. So this is a slide that's lifted directly from the CMS materials that describe the ahead model. You can kind of see, like, it's almost like the HSCRC developed this slide, right? It's like pretty aligned with what we built in the total cost of care model. And when you compare, stack the two models side by side, you really start to see, hey, there are some major parallels, right? So the ahead model certainly builds on the total cost of care model. I think that is not coincidental, right? I think CMS is looking to leverage some of what we've built together here in Maryland more broadly across the nation. So the Maryland health model, continues to be important to our state, right? We've talked about some of the ways that the model improves the quality of life of Marylanders. Again, controlling costs, controlling underlying costs in healthcare is something that cannot be understated in its importance to Marylanders, right? And it is something where, like, look, previous to coming to, as James mentioned, previous to coming here, I was at HMA. I was working with, I don't know, in the last year, about a dozen states. They were all looking to impact underlying costs of care. So in other words, not just subsidized coverage, right, but how do we start to move the needle on underlying costs? And a lot of them were coming up blanks, right? We don't have a whole lot of tools to do that. So really critical. But I think certainly building off of this, I think is critical. And again, why ahead? Certainly it affords us opportunities to do that kind of footprint expansion, expand our impact on population health. But I also want to underscore that the ahead model is the pathway, right, that CMS has laid out for us to continue the model on, inclusive of the waivers that we benefit from for Medicare payment, right? So just want to highlight that. Myself, the health secretary, really kicked the tires on the ahead model before CMS went into their blackout period to make sure that we would be provided with the flexibility that we need to make sure that the AHEAD model isn't a step back, right? So when you read some of the materials that they've released, right, you can see that a lot of it is kind of like a starter kit for states, right, who are at the beginning of their journey. We wanted to make sure, and I think got the assurance from CMS, that we would not have to step backwards in order to participate in AHEAD. That's really, really critical for the folks in this room to keep in mind, right? We can build off of what we've built, right? So, so that's really important. But the AHEAD model is the pathway to get to that outcome. Okay, so I'm not going to spend a whole lot of time on this. I think this room knows a lot of this stuff as well as anybody else. We've got a lot of infrastructure in place that would put us in a position to succeed within the AHEAD model. CMS knows it, we know it, right? I think this is a really critical thing to focus on, right? And it ranges from everything from kind of the financial policies that we have put in place. James mentioned CRISP. That's a huge resource within the state that as we think about, hey, driving population health impact, we're going to need data to do that. Well, we've got a lot of data aggregated and accessible, right? So we've got a range of assets within the state to highlight in our application here. Let me talk about, while we have assets, there are a few gaps that we're going to have to figure out and evolve. You know, one of them is around cost targets, right? So currently, we're principally in the Medicare realm. As we move forward, that's going to have to expand, right? One thing that I'll note here that I think is relevant for this audience in particular is that hospital global budgets, our status quo is pretty good, right? In terms of what the model would require. But that doesn't mean that we as a state wouldn't want to evolve our global budgets. And so I think we will have a lot of conversation about, hey, look, what could we do within global budgets to make things work better for our state, right? That is a lot of the work that I think we will need your help on. We are currently in process of developing our response to the notice of funding opportunity. Let me pause here for a moment and explain what the NOFO is and what it isn't. So we've set up 3 advisory committees. Some of the folks in the room sit on these advisory committees, right? To really advise our response to the NOFO. The NOFO is at its core, it is not a statement of what our model will be. It is more, I would think of it, an expression of our ability to meet the requirements of the AHEAD model, right? So it's an inventory of our assets, an expression of our approach to designing elements of the model, right? What are the challenges that we would anticipate that we're gonna see, right? Very importantly to them, how will you use the roughly $2 million a year that they will provide, right? That money will go very quickly. It will be more of a value expression of like what we think that we want to accelerate here within the state, right? That's really important because when you think about the NOFO, I think a lot of people think of it as like, hey, if it's not in the NOFO, it's not going to be in the model. It's not the case. This is really our application, our opportunity to tell CMS, hey, we're ready to enter into model development, right? So we're close, relatively close to submitting that NOFO response. Hopefully we'll get the award in May or June, and then it's off to the races, right? We'll be in an 18-month sprint with all of you and other stakeholders around the state to develop the model and negotiate, and that's where the negotiation with CMS really begins, right? So hold on to your hat, because it's going to be a busy 18 months, right? So with that, you know, I think we've done a lot within the state over the last decade. We have a lot of opportunity in front of us with the AHEAD model. I keep saying we have a lot of opportunity ahead of us in the AHEAD model, which sounds so stupid, and I'm just so angry that they called it the AHEAD model. But we have a lot of opportunity. We look forward to working with all of you to realize that opportunity and then operationalize that opportunity as we move forward over the years here. So let me, I think, James, do I have a couple minutes for? Okay. So let me open it up to questions, thoughts.
Questions. I sound like Brett McCone. Questions, thoughts.
We miss Brett.
Hey, John. I had a quick question. You repeated this statement, underlying costs, right? Can you explain to us what are the components so you better understand what do we mean by that?
Yeah. So underlying costs, I would put a number of things in that bucket. I mean, there's certainly administrative costs and so forth. But really what I mean in this context is the costs of delivering care, right? Specifically the costs of delivering care, because there's a lot of healthcare costs that overlay that around financing of care and supplementing it, right? And so when we think about underlying costs, we might categorize that in two parts. One is the direct costs of providing clinical services, and then we have a couple tools within that, right? I mean, there's avoiding avoidable utilization, and then there are things that we can do to reduce the unit cost of that, such as shifting from a high cost setting to a low cost setting, right? So I think that's one component. The other is really more, if you look at that from a kind of population health framework, might also be preventing future costs, right? So that would be investments upstream where we're getting out into community settings and we're preventing either the cost of services because we're reducing the acuity, we're delaying the progression of disease, et cetera, right? So I think those are like kind of the two lenses that I would think about when we think about the AHEAD model, right?
Other questions? This is like walking down the aisle of a Southwest flight. Like nobody's making eye contact with me, so I don't choose them.
We got a question over here. Yeah.
John, I'm trying to do the math up here. So we're looking at, I think you've got 2026 implementation here, but we're looking at like a rate year 27 effect. Am I doing the math right, or is it really going to be rate year 26?
So it depends. That's the true answer here. So our current model goes through 26, right? I think what the AHEAD model materials that have been released describes is a start date of the new model at the beginning of 26. So we've got an overlap there. So I think as we get into negotiations, we're going to figure out exactly what those two overlapping timeframes mean, right?
Any last questions?
I can hear you just
Okay,
fine.
so Laura Russell, Maryland Hospital Association. Thank you so much for your presentation. So I have a public health background,
Yeah.
and you talked about health equity and developing a health equity measure. And so as we look at some of these things driving up the cost of care, it's a lot of chronic conditions. And we know that with chronic conditions, it's going to require a lot of health behavior change, and that's not easy, and it takes a really long time to achieve that. And there are things that are difficult to measure as well. And so I'm curious, with your background, can you talk a little bit about what you've seen in terms of health equity measures, what we might look to measure, and what is a reasonable time frame for being able to measure that?
Yeah.
Thank you.
Well, let me start with the time frame element of that, because I think that's the really that is one of the more challenging aspects of it. I think it's okay for us to say that we're going to measure different things in this model on different time frames, right? And some of the horizons, quite honestly, if we're talking about some of the very, very upstream social needs investments, may not even result in total cost of care impacts within the lifespan of the next model. But that's okay. That should, we should still value that and bake that in the model, right? What I would say is two things. I think a lot of the equity work that I have seen has largely been essentially quality outcome focused. I don't know that that's going to be ultimately the right framework for us. And so there are a bunch of folks, or let me correct that, exclusively the right framework for us. It's going to be an important component of it, and a lot of those measures exist. We'll probably have to invent some. There's this other aspect of it, which is more from a broader social sciences framework, right, where we would look at kind of measures of social equity, right, that we will have to figure out, does that align or drive health equity, right? And then there's a third aspect of it that I think a lot of the folks at the HSCRC are going to have to help drive, and frankly, a lot of folks within the broader healthcare finance community are going to have to drive, which is, given those different time frames, how do we invent a framework that has never been invented before that ties back these investments to total cost of care impact? I view that really as one of the harder tasks within this model development, and we may not get there in the 18 months, right? That's probably going to have to evolve over time. We're going to be inventing methodologies together. So all of that is to say, some of our focus now is not so much on defining those measures. It's on building the capabilities and capacity to develop those measures over time. So do we have the data? We have actually some really great race and ethnicity data here in the state. We have obviously good claims data in a lot of parts of our healthcare landscape. We have a lot of gaps though, right? So we need to work on that. Do we have the right resources at the state? Allison is over there, right? Jeff is somewhere around here. These are like super brains, right, that we can leverage toward these challenges. But we're going to need to make sure that we have the right teams in place. We're going to have to borrow from the department. The department's going to be a huge part of this as well. So again, I'm not, Laura, answering your question totally, other than to say, well, I don't know, some of these things don't exist. we're focused on building the capabilities to make sure that we can develop what we need in order to measure and track impact. That's a long answer for I don't know.
Like a true former consultant.
Yeah,
Thank you,
I'll
John,
fill you.
for your time. Round of applause for John.
All right.
All right. Shift change. There's plenty of seats up front here. If you're just coming in, you want to make sure you get your questions answered. You can sit right up front today. So, all right. Our next speaker, we had a smooth transition there with Laura asking a question. Laura will actually be our next speaker. Laura Russell is the Director of Healthcare Payment for the Maryland Hospital Association. Laura leads MHA's comprehensive advocacy strategy for Maryland hospitals on payment-related issues. Prior to MHA, Laura held a position in population health program management for the University of Maryland Medical System, and she is also a graduate of the George Washington University with a master's in public health. So please help me in welcoming Laura Russell.
All right. Good morning, everyone. Can you hear me okay? All right. So I would like to thank the Planning Committee for inviting MHA to speak today. It is a pleasure to be here. I think this is a great resource for those of you who might be entering the field. I know when I entered the Maryland healthcare landscape, I wasn't necessarily aware of this, and it is a huge learning curve. So I'd like to thank HFMA for putting this on. And for those of you that have been in the field for a while, I'm hoping that I can bring to you today a little bit of an update of what we're doing. I'm hoping that I can be a little complimentary to John and what you just heard about what HSCRC is looking to do as we think about the new AHEAD model, as we think about some of the payment policies coming down the pike, and other factors that are influencing our hospital payments and how we deliver care in an innovative way. I'd also like to just take a second and thank my team at MHA who put together the majority of the slides for me today. I think I might have made like 3 of them, so I have to give them credit. They're doing some amazing work, have some amazing visuals for you all. So with that being said, I'm hoping I won't repeat John in talking through AHEAD, but hoping to give you a flavor of what hospitals are thinking about as we enter into the AHEAD model, which is going to be our path forward with CMMI. My presentation today is going to be focused heavily on the finance because that is what I do, and this is HFMA, but I am hoping that I can give you a comprehensive view of everything else that MHA is working on. We have our legislative session that's occurring right now. There's a lot of work going on in Annapolis. We have a quality and health improvement team that is doing some really great work on health equity and maternal and child health outcomes. And so I'm really excited to share that with you today, and hopefully we'll have some time at the end for a little bit of dialogue. Here are my learning objectives for today. I'm not going to go through them. The one thing that I would like to say, though, is that I'm hoping that I can give you a perspective today of some of the micro and macro level influencers of payment, of how hospitals are delivering care in terms of what's going on nationally. Right? What are some of the regulations and laws that are affecting us and what we do, what's going on in the environment, things like that, because I think sometimes that we can get so very narrow-minded, but we have to bring ourselves back up to this level, right? And think about everything that's influencing the work that we do. Okay, so I'd like to start off talking about the AHEAD model. This is a different look at the timeline that John just showed you, and so I'm not going to rehash any of that, but some things that we have to consider as we're entering this new model. What's happening in November? Anyone know? Can anyone tell me? We have a presidential election. So with a presidential election, we might be under a new administration, don't know yet, right? And so what happens when we have a new administration? New priorities, right? And so that's something that as we enter this pre-implementation period, knowing the outcomes of the election, we're going to have to think through that, and we might have to navigate some changes in priorities, right? As we think about implementation, it shouldn't necessarily halt any of the good work that we're doing, but it is something that we're going to have to navigate. We just got a new governor not too long ago, but that could change, right? And so that's something that we're going to have to think through at a state level. And so that's all I'm going to say in terms of implementation of AHEAD. We know now that that is our path forward. I think that gives us a little better certainty of what's going to happen. We didn't know what we might be entering into with our contract, and now we know that we're definitively moving towards the AHEAD model. Here are some key considerations from the hospital field that we're thinking about as we enter the model, and we're having some really good conversations with the folks at the department and the HSCRC around this. As John mentioned, we checked the box in everything that the AHEAD model is proposing, so advanced primary care and primary care investment, population health and health equity. And we are the model for hospital global budgets. All of our hospitals pretty much are on global budgets, and the requirement for AHEAD is, I think it's 30% has to be in GBR. So we are definitely going to be viewed as the leader in this space, and that's really exciting, actually, right? And as John talked about, we have some opportunity to continue to innovate. So the AHEAD model is not going to hold us back, but we have opportunity to refine things, think about things a little differently, and really be a leader in healthcare reform. And so some key considerations that I bucketed out that the field is thinking about. One is around GBR and financial. So we know that a main component of our model is all payer growth. And as we saw on the dashboard this morning, we're knocking it out of the park in terms of that. We're doing really well, right? And so I know with CMMI, we tend to get really focused on this Medicare savings target, but comprehensively, we need to be thinking about what is the benefit for all Marylanders, right, which we're affecting. So, you know, in the commercial population, you might have some different considerations. There's a lot of pediatric care, right? And so what do we need to be thinking about there? What's the benefit? Those are all things that are really important. John spoke a little bit about guardrails in his presentation this morning. I think there's some opportunity for refinement, as he mentioned, moving forward. We're learning some lessons, and one of those is that if hospitals want to continue to invest in community and population health, we need some stability, we need some predictability. These are really long-term investments, right? And so sometimes when we have these year-over-year guardrails, it doesn't give us the predictability to be able to do that. So how can we be thinking about that a little differently? And then excess savings. This is really important, right? Because anything that we generate in excess of our target, that goes back to the Medicare Trust Fund. But should it go back to the state? And should it benefit us? That's the question that I have, right? In terms of population health, you're going to see a lot more comprehensive stakeholder accountability. And when I talk about accountability, it's not in a punitive way, but rather it's how are we all working together synergistically? I think there are some things that hospitals are really great at, and we can influence health, but then there are points where we need to hand it off to others that are, quite frankly, a little better equipped to do the work. That might be community health workers that actually are trusted to deliver care or influence the health of, the communities in which they work in. So thinking synergistically of how we can really work together to advance the goals under the model. We're thinking about health-related social needs. This is a big driver of health outcomes, right? So when I was in a health system previously, we saw a lot of people come through the ED and they coming back because they didn't have stable housing, right? And we know that cost has gone way up. And so those are things that we're going to have to continue to address and be really innovative about. And then access to care, that's really important too. We're generating these savings. However, we need to make sure that there are some checkpoints around the way, right? So we need to make sure that anything that we're doing is not limiting access to care. And then in the primary care space, I was at a health system previously, and I did a little bit of work with the Maryland Primary Care Program. And one thing that we need to think about is practice needs, right? So you might have some small or rural primary care practices that have a little bit of difficulty meeting advanced primary care requirements, like having a care manager or integrating behavioral health, because they might have one or two docs, right? So thinking about how we can bring them along and create an avenue to allow them to participate in this model. Underserved population. So I think this is a space where John talked about we have some really great data. Let's use it to make sure that we are targeting those communities that really need it and lifting them up. And then a lot of really good work is happening in the payer alignment space, especially in terms of Medicaid integration. And so when I worked in value-based care, some of the pushback that I used to get from these docs is, okay, I have these measures from this payer, I have Medicare wanting me to do this, I have Medicaid wanting me to do that, right? So we don't want to create a burden on providers. They're there to help people, right? We want to streamline things where we can, because at the end of the day, we're not cherry picking our patients, right? They should have the same access to care no matter what insurance they're under. So thinking about that a little bit as we enter the HEAD model. So now I'm going to give you a look at MHA's financial policy priorities for the current fiscal year. You'll see some alignment with the work that HSCRC is doing. So these are core focus areas for our members. So our first priority is objectively looking at the conditions that will influence this year's payment update to hospital rates. So as you'll see in the next few slides, we're performing well on our waiver tests, but we had a pandemic occur, all right? So it's been 4 years. We're not going back to the way things were. And I kind of equate this to what happened after 9/11. So I remember being a very young child, and my parents went to Hawaii without my sister and I. I was so devastated. As a parent, now I understand, right? They needed to get away. However, one thing that happened was my pop-pop or my grandpa, he took me right up to the terminal when my parents got home to see the plane come in, and I thought it was the greatest thing ever as a young kid. You can't do that anymore. You're never going to be able to do that again, right? And so there are some things as we think about the aftershock of the pandemic, they're never going to go back to normal. So one example of this is labor. it's gone up, and you've seen permanent increases in that. So we have a new expense base, and we need to be thinking about that. It's creating a huge cost pressure. We're thinking a little bit, or actually a lot of it, about the ahead financial goals and metrics. I talked about that on the previous slide. In terms of assessing hospital financial conditions, I'll get into that in a little bit. We tend to focus a lot on hospital margins. However, there are a lot of things that go into hospital ratings and being able to access things like bonds. And so I want to walk you through a little bit of that today, because I think it's important that we take a more comprehensive view of hospital financial conditions. And then HSCRC payment policies. You saw that the commission is going to put out a policy agenda next week. And so we want to be working collaboratively with the commission. Hospitals are the ones that are the main implementers of these policies. And so we need to make sure that as we're developing these policies, that we're giving good feedback to the HSCRC to be able to affect change on them. And then understanding physician losses. This has been a really important topic lately. So physician compensation in Maryland is quite low compared to the rest of the nation. And as a result, we've seen hospital-employed physicians and rising subsidies. This is a critical component to ensuring access to care, and it's something that we're working with the commission on so we can better understand what's driving these losses. So here's MHA's look at model performance, which is some of the information that John provided. But what this dashboard shows is we're on track to meet all of our waiver guardrails in this calendar year. And we're well below our all-payer growth target, as I mentioned, and we're on track to meet our cumulative savings target. So here's another look at how we're performing on savings. So as of the last update from the commission, we're looking at a run rate of about $500 million. And that is just taking the current savings and adding it to the previous years. There were some one-time adjustments that occurred. If you take that out, that number is actually a little lower. I think it's actually around 400 million or a little above that. However, the takeaway here is we're doing quite well in this calendar year. And then finally, looking at hospital and non-hospital growth, you'll see the main driver of savings is we're getting hospital growth down, and that's what should be happening under our waiver. We want to drive down unnecessary utilization, right? There's still some appropriate care. There's still people that are going to need hospitals, but we want to get the unnecessary utilization out of the hospitals, and we want to be driving people more towards primary care, preventative health measures. And so you'll see the non-hospital growth go up a bit, but the idea is it's a lower cost setting, so that's okay, right? So I wanted to start out this slide with a little bit of a personal experience of mine. I was cleaning my son's room the other day, and I came across this card right here. And what this is a fetal alert. My son was born with 2 ASDs and 2 VSDs. And what that means is he had 4 holes in his heart when he was born. We knew about 3 of these in utero, and it was honestly the most nerve-wracking time of my life, and it was probably the most difficult experience I'll ever have. I spent every Friday for about 4 hours hooked up to fetal monitoring and talking to my OBGYN, who was a high-risk provider. Fortunately, he's okay now. He's thriving. I wanted to let you know that, but I carried this card around saying that whatever hospital he was born at, he required a fetal echo to check up on his heart. Now, drawing your attention to the bottom headline here, I can't imagine how much more nerve-wracking it would have been knowing that there weren't good labor and delivery services available and that access to care, access to a high-risk OBGYN. If I had lived in another state where this wasn't available, I would have had to pack my whole life up just so that I could be near a hospital to deliver my son and get him into a NICU so that he could be assessed. And I bring this to your attention because when we think about adequacy of payments, we have to think about access to care. Okay, it's not just about the financials. It's about, are we able to provide access to something that everyone should have access to? I came across a really exciting article the other day, and it's that we're curing sickle cell disease, right? There is a new therapy available that basically alters genes, and that's really exciting. And it's something that's not going to stop in terms of innovation. Like, these things are happening at a faster pace. But unfortunately, the downside of that, and something that we have to grapple, is that treatment costs about $2.2 million, right? I don't think anyone would argue that we shouldn't be able to administer this, but it's something that we have to think about, and it's something that we have to incorporate into our payment adequacy framework. We talked about the new normal now, and so some of these other headlines show what hospitals are facing nationally. So I came across this report the other day about hospitals closing departments or ending services. Something that was great in Maryland during the pandemic is that our GBR model provided stability for us, but that's not to say that hospitals in Maryland aren't facing these cost pressures. So now I'm going to walk you through a little bit of the metrics that we look at in terms of hospital financial conditions. And so these are some metrics that some of the rating agencies look at in determining the financial outlook for hospitals, and it's really important in terms of access to bonds and things like that. So looking at the most recent independent credit ratings for our hospital in Maryland, we've seen them slip a little bit in terms of the financial pressures we've been facing over the past few years. So this slide shows ratings from trusted sources like S&P, Moody's, and Fitch. And as you can see, several hospitals had a negative outlook. What this slide shows is hospital margins in Maryland compared to the nation from fiscal year 2021 to 2024. And the takeaway here is margins remain depressed, though improving slightly. And so now for some other metrics that we look at and some takeaways that we have in terms of what it means to hospitals from a financial and care delivery standpoint. So the next slide, this slide looks at metrics used by sources such as lenders, underwriters, financial advisors, and rating agencies. And what you'll see is Maryland hospitals compared to national peers and we have the inclusion of 3 large national health systems to capture broad performance characteristics. The dashboard includes a number of entities from adjacent states, and the purpose of this is to capture regional performance that is similar to Maryland's demographic, hospital sizes, and their scope. And so what this slide shows is average age of plant. It's an indicator of the current condition of physical facilities and the need for future investment. So what you'll see here is Maryland hospitals have a higher age of plant compared to their national peers. And so we're going to be needing to make some capital investments. Here is a look at days cash on hand. It's the number of days that an organization can continue to pay its operating expenses given the amount of cash available. So hospitals with higher ratings tend to have more days cash on hand is the way you want to look at this slide. We have high liquidity that remains a bright spot for the industry. For cash to debt ratio, this is an indicator of how long it would take for a company to repay its debt if it devoted all its cash towards debt payment. And so what you'll see is cash to debt is lower in Maryland. We have lower cash and higher debt. Okay, can we get the next slide? I'm sorry, I think this may have lost its battery here. Okay, go back. No. I think, yes, debt to capital. So this shows the proportion of debt that a business uses to fund its ongoing operations as compared with capital. So Maryland hospitals are in line with the sample, but worse than the rating medians here. Thank you. This is a look at inflation, and so what we were funded compared to what was predicted in terms of inflation. It's a little bit of a lagging indicator, unfortunately. We have some instances where we've had overfunding of inflation, but during the pandemic, we had a severe cost shock that was absorbed. And so right now we're looking at cumulative underfunding. And from a cost inflation standpoint, wanted to bring your attention that MedPAC released a recommendation for the IPPS, OPPS national payment system in December. Now, their recommendation may not ultimately get adopted in August. However, what they included in their recommendation is to add 1.5% to what's in current law, and that's based on their payment adequacy framework. So it looks at things like access to care, quality of care provided, hospital financial conditions, for example. So the takeaway there is that they're well aware of some of these cost pressures and the need to address them. I mentioned physician reimbursement at the beginning of my presentation. We know that the inability to cost shift in Maryland is contributing to lower reimbursement, as shown on the slide. And in order to employ and retain physicians, hospitals and health systems are increasingly employing these providers. And so as you'll hear later today, we're working with the commission. They're doing some work to better understand how these costs are captured, what the magnitude is. And so from the association's standpoint, we're working to inform the work they're doing. Spoiler alert, sorry. So what are the takeaways from our financial performance? So we're on track to exceed our 2023 target. However, margins and cash remain depressed. We have to have careful management of that. And as we think about that, this kind of inhibits our ability to make some of those long-term investments. If we're thinking about can we at least provide the core services that we need to as a hospital, right? Some considerations that we're thinking through as a field. We work on a lot of other financial related matters. Sorry, I got the flu last week, and my voice is a little hoarse, so I apologize. From a regulatory perspective, you'll hear from the commission today that there's a lot of work going on to refine some of the volume policies, and so providing perspectives from a field on that. John mentioned Revenue for Reform and Efficiency. That program was very new this past year, and hospitals that were ranked as inefficient had the opportunity to present their population health investments in order not to have some of that money removed, recognizing that they're making population health investments. And so we're looking to learn from that experience and continue to refine the criteria. So we look forward to that work effort. In terms of financial assistance and debt collection, there have been some changes to the law that have been implemented over the past few years to capture hospital practices. And then in terms of hospital throughput, we're seeing ED overcrowding in Maryland, higher than the nation, and our government affairs and quality improvement team have been working with the commission to assess ED wait times and promote best practices. So there's some collaboratives going on there at MHA. And then we've seen an increase in payer denials over the past year that we're looking to better understand and address. And so this is some ongoing work. There is not a dearth of things to do at MHA. So now that I went through some of the more technical financial matters, I'd like to bring your awareness to some of the other work that our quality and health improvement teams are doing and our government affairs teams are embarking on. And so the first is quality and health improvement priorities. In terms of health equity, a key tenet of our strategic plan involves transforming culture and care through equity, advocacy, and collaboration. And so this includes achieving health equity and quality and clinical outcomes and developing the capacity for a diverse, inclusive, and equitable workforce. We continue to work toward the healthcare goal of having an environment where hospitals are delivering care in an efficient manner. And so we'll see a call once again to improve performance on HCAP scores. And then we have specific incentives on hospitals for population health functions. Looking ahead, we'll continue to work with the HSCRC on digital quality measures. As I mentioned on the previous slide, assessing ED throughput remains a key priority for us. We've engaged in several activities through our collaborative, and this is not just an MHA effort. We're collaborating with stakeholders such as MIMS, for example. So it's going to take multiple stakeholders to help address this issue. And then in maternal health, we are looking to reduce severe maternal morbidity, and that's one of the population health goals under the statewide integrated health improvement strategy. I'm glad I got that acronym right because there are a lot of acronyms in healthcare. And so we've been bringing together clinical and executive leaders of our birthing hospitals to strengthen the maternal health teams. So here's a look at our 2024 legislative agenda. For those of you who may not be as familiar, in Maryland, our legislative session runs from January to about March or April. It's a little different in every state. This shows a snapshot of our agenda that was approved by our Board of Trustees in November. And then the next couple of slides, I'll get into some of our specific activities. A lot going on in Annapolis right now. So in order to ensure access to care and improve hospital throughput for all Marylanders, we submitted a request to Governor Moore asking him to include a $25 million reduction of the Medicaid deficit assessment in fiscal year 2025. In our letter, we acknowledged the anticipated shortfall and asked him to consider investing in the healthcare workforce if a reduction is not possible. For the capital budget, our hospital bond program review committee recommended 6 projects to achieve $6.8 million. We'll advocate before the Senate and the House to protect this funding. And then the 988 program is the behavioral health crisis line in Maryland, and since its inception, it has benefited from a budget surplus. And so last session, the bill mandated a one-time $12 million appropriation for the program. However, it doesn't have a dedicated funding source. So we're joining the coalition, and many member hospitals are already a part of the coalition, and we'll be advocating for a small tax on cell phones to go directly to the trust fund. And then on the last bullet, a brief history of Senate Bill 760. It passed during the 2023 legislative session. And so the purpose of this bill is for unregulated security guards, such as it's for unregulated security guards. Hospital security guards are already regulated. However, legislation was introduced in response to situations where security guards were involved in use of force. And so you might have heard some of these stories that happened in the region. And the hospital field was under the impression that legislation was not meant to impact hospital security, so we didn't get involved in this bill. But at the end of the process, it became clear it would impact hospital security. So we tried to amend the bill to exclude healthcare security officers, but we were unfortunately unsuccessful. So the bill doesn't go into effect until June 2024. So what we're currently doing is working with sponsors to get security exempted, given our regulation from the Joint Commission, CMS, and OHCQ. Don't ask me to spell that acronym out. I can't remember right now. All right, so strengthening Maryland's healthcare and hospital workforce. Through our budget advocacy work, we asked to maintain the $3 million funding for the Maryland Nurse Loan Repayment Program, and increase funding for a one-year awareness campaign as recommended by the Preventing Workplace Violence in Healthcare Settings and Public Awareness Campaign Workgroup. That is a mouthful. We also plan to support the APRN Compact, which has support of the National Council of State Boards of Nursing and the Maryland Board of Nursing as well. And then lastly, on Maryland's liability climate. We're poised to defend against any proposed changes to increase or eliminate Maryland's higher than average caps on non-economic damages and civil claims. And so our government affairs team has been extremely busy in Annapolis. So that's my presentation. That's an update on our priorities. Again, a lot of collaborative work going on. We're really excited about the AHEAD model and implementing that with the state. I know that the advisory committee discussions have been good so far, and as we look toward implementation, we'll be closely partnered with the state on that. So with that, I'd like to thank everyone for your time today and open it up for questions.
Questions?
Hi, Laura. Quick question for us. You had mentioned, and I'm just trying to go back to my notes here, that MD model performance was a slide, I believe, up there. What's the underlying data?
The underlying data. So this is the same information that the HSCRC uses. It's the Medicare claims data that the commission is using to project model performance. It is the same look as what was presented at their last meeting, which was their January meeting. So we'll have a refresh of that in February.
So just a follow-up question. So this is primarily public data, correct?
No, this is not public data. This is data that the commission gets. We at the Hospital Association have an agreement with the HSCRC, and so we actually get the savings performance data around the same time that they're releasing it. So. For the public meeting. So we have access to this information. We create the dashboard and track growth concurrently with the HSCRC.
Thank you.
Yep.
Other questions? You guys know I love a long, if you've been here for 7 years, you know I love a long, awkward silence until somebody raises a question. All right, well, thank you very much, Laura, for your presentation. Allison received her doctorate in health services research from the Johns Hopkins Bloomberg School of Public Health. And before she worked at the HSCRC, she actually worked for Johns Hopkins Healthcare. Dr. Jeff Doherty is also a deputy director with the HSCRC, where he leads the agency's efforts to measure and incentivize population health improvements under the model. Jeff is also an MPH and PhD holder in epidemiology, a class that I failed at Hopkins the first time around, from the Johns Hopkins Bloomberg School of Public Health. So I should have used Jeff to cheat off his homework. So without further ado, please welcome Jeff and Allison.
Good morning. Good to be with you guys. I guess I'm personally going to judge the success of this talk by whether my water bottle ends up on top of my laptop, but you guys should feel free to apply your own metrics. Here's what we're up to. At the end of the session, we hope that you will be able to do a couple of things. Understand the historical context of ED length of stay and utilization in Maryland. Identify hospital and regional factors associated with ED length of stay, and understand HSCRC's initiatives to address ED length of stay. So I'll spend just a second orientating all of us to the situation in Maryland with ED performance, but not a ton of time because I think you're all probably pretty familiar with it. I don't think this will come as a surprise to anybody that Maryland's performance has been a little rocky since the public reporting on ED length of stay first began back in 2012. We'll note that this is actually before the advent of the total cost of care model and global budgets, so I think there's a pretty good sense that this is something that's not necessarily caused by global budgets, but is co-occurring. That performance gap has remained relatively unchanged. And then here's looking at those same data points by hospital volume, and you can see that across most of these categories, the hospitals in Maryland are performing worse than the nation. At the same time, we have less ED volume than most hospitals in the nation. And so that's, I think, probably a little bit of a function of the model. You can see it's been declining over time. And you can sort of intuit that that's probably due to things like case management investments, primary care, alternate care sites, and things like that. But I guess the important piece of this is that the decline in ED volume is really not depressurizing Maryland's emergency departments. And so we think that probably other factors may be driving ED length of stay outside of volume. And I think one other thing that's important to note is that we see a pretty tight connection between ED performance and Maryland hospitals' performance on patient satisfaction indices, which have also been kind of a challenging spot for hospitals in Maryland over time. And it's not surprising that a significant number of admissions come from the ED. If you've just waited 12 plus hours to be processed through the ED and get to your inpatient bed, then you may not be super happy at the end of that process. So in order to provide a little bit of context for how EDs are working in Maryland and how our situation fits into national trends and performance on ED length of stay, we did some analysis that was presented at the MHA ED Performance Task Force that was convened by the legislature. We thought it would be helpful to share a little bit of that information with you guys here today. So in order to try to understand what was going on in emergency departments, we put together a statistical model that included both hospital referral regions. There's about 300 of them in the nation, and individual hospitals. We ended up including like 3,000 hospitals across the nation in this effort. The model assesses the degree to which each determinant that we looked at, and we'll get into what we looked at in a minute, is associated with the ED length of stay. So the interpretation is something like a change of 1 year in median population age is associated with an increase of 10 minutes in ED length of stay. The model also provides guidance on what proportion of variation in LOS is driven by hospital referral regions and hospital-specific factors. So we're kind of disambiguating those big regional, I guess, policy issues from the hospital level operations issues, and understanding how strong the connection is between each of those things and ED length of stay. And then we dug a little bit deeper to look particularly at the dynamics around one thing that we think is really important, which is the inpatient occupancy rate, which is clearly driving a lot of boarding time in the ED. So we did this using a whole pile of data. One key source was the 2019 American Hospital Association survey. I'm sure you guys are pretty familiar with that. That has information on ED volume, inpatient volume, the services provided at each hospital, some other structural kinds of things, and inpatient occupancy levels. We also pulled in data from the census, the social vulnerability index from the CDC, CMS information on SNFs per capita, and the Dartmouth Atlas information on primary care access and surgical volume. So to give you the headlines from this effort, we found that the differences between hospital referral regions accounted for 37% of the variation in median time from ED arrival to departure. So this is the ED1B measure. We also looked at this on a couple of other ED performance measures, OP18 and so on and so forth, and found basically the same things. Differences between hospitals within HRRs accounted for about 63% of the variation. So what we're saying here is that hospital factors like staffing, bed management, organizational structure, and so on are likely bigger drivers of ED performance than these kind of regional policy and context issues. Not to say that regional factors like inpatient beds per capita, SNF beds per capita aren't important, but they are less significant drivers than the hospital-specific stuff. We also found primary care access as an important and potentially modifiable determinant of ED length of stay. Social determinants as well fit into that category. And then structural hospital factors like bed size, complexity, teaching status, and so on that are not quite as modifiable also have a really big impact on this stuff. So this is a figure that shows the relative strength of each of these things that we looked at. We've done away with all of the stuff that was not statistically significant, so this is just kind of the leading contenders. And so what you can see here is that primary care providers per capita decreases ED length of stay a little bit, and that confidence interval shows you that that's statistically significant. The percentage of Medicare patients receiving an annual wellness visit, so again, an indication of primary care intensity, also reduces length of stay. You can see that increases in the social vulnerability index increase ED length of stay, as do ED volume, hospital complexity, the hospital occupancy percentage, the teaching hospital status, and then bed size is also probably the biggest driver on the positive side. So to sum up some of these dynamics here, I think it's important to note Maryland hospitals are larger, more complex, and more likely to be teaching hospitals. All of those things are associated with longer ED length of stay. So this is really a blessing and a curse at the same time, right? Larger, higher volume, and more complex hospitals typically are providing better outcomes for patients in terms of risk-adjusted mortality, readmission, and inpatient length of stay. But there's really a cost to that comes in ED performance. So after you account for those structural differences in Maryland hospitals versus other hospitals, you're left with the picture that Maryland hospitals are really not that different from the nation in their ED performance. In fact, they're statistically indistinguishable from the nation in terms of ED performance. But so I think that's good to know. I think that takes a little bit of the heat off in terms of just the level of rhetoric around hospital performance. But it's also important to note that our patients are still waiting a really long time in the ED, and we still need to do something about that. So I think this frames up the question in an interesting way, which is there are big, complicated teaching hospitals nationally that perform well in ED length of stay. And so the question then becomes, how do we crack that code to be able to provide our residents with the benefit of this really highly evolved healthcare ecosystem that has a lot of big teaching hospitals that perform really well on patient care, but also have them perform really well on ED performance. So I think it's a tough question, but one that's very much worth answering. So occupancy always comes up in terms of these discussions, and so we decided to take a specific look at that. Occupancy, no surprise, is an important determinant of ED length of stay, and a complicated dynamic in its own right. So we dug into that by looking at the independent association of a bunch of variables with inpatient occupancy. So inpatient beds per capita, length of stay, end-of-life care, SNF beds per capita, and surgical volume. And for the technically minded among you, we looked at occupancy as the AHA reported inpatient bed days divided by 365 times inpatient beds staffed at end of year. So that's the occupancy piece that we're looking at here. And then here's a similar figure that shows the association of those things that I just mentioned with inpatient occupancy. So surgical volume, length of stay, end-of-life ICU days, and SNF availability were significant determinants of occupancy. Maryland differs unfavorably from the nation on most of those measures, so we've got our work cut out for us. Inpatient beds per capita, which comes up as a really frequent topic of discussion in the media and as a potential solution here, is less associated with performance here and did not rise to the level of statistical significance. So I think we would probably push folks to look at some of these other buckets of potential interventions before we start talking about bumping up inpatient beds per capita. Maryland beds per capita are actually lower than the national average, not surprisingly, due to reduced demand under the TCOC model. So we do have lower beds, but I think it's important to note that a lot of that is probably because of the impact of the model on demand. So to sum this up, what does this tell us about where we might want to go policy-wise? So policies addressing primary care could potentially result in improved ED length of stay. So things like reimbursement enhancements, MDPCP, investing in additional primary care supply in terms of physicians and offices. Addressing social determinants can also potentially improve ED length of stay. Policies that affect inpatient occupancy can have a big impact on ED length of stay. So things like improved hospice access, improved SNF access, planning elective surgery and medical admissions, and balancing those two things to avoid constraining ED admissions to the inpatient service can have a pretty big impact. Increasing inpatient bed capacity is not likely to be a viable and sustainable solution to this problem. And there's a couple of reasons for that. If you sort of think carefully about the stuff that we just went through, that, you know, our hospitals are larger and more complex, and teaching hospitals, stacking more beds in those places is just going to make them even larger and more complex. And so that's not necessarily something that's associated with improved ED length of stay. And so probably not a place where we could count on getting really good ROI from that type of investment. Expanding inpatient capacity would also likely be a costly long-range solution that has negative implications for TCOC model performance. And I think we can all agree that we're probably looking to make maximum headway on this issue in the short term rather than the long term. So I think the time frame that we're looking at is probably not a time frame that's consistent with really scaling up inpatient bed capacity. I should say that what I mean there is, you know, developing new inpatient beds. I think there's obviously some things that we can take up in terms of staffing beds that are not currently staffed, repurposing beds and things like that. And all those, I think, can occur on a much more shorter and effective time frame. So I guess the takeaway there is that other interventions that we've been discussing here may provide similar or better outcomes with limited cost and downside as compared to building new beds. So with that, I will turn it over to Dr. Schuster, who's going to talk about policy goals and then some of the stuff with the EDDI program.
Thank you. It's nice to see everybody this morning, and I know that there's been a lot of interest in the work that the HSCRC is doing around emergency department length of stay, and you know, we know that long lengths of stay and the research is associated with worse outcomes, higher mortality, delays in care, more opportunities for errors. So in addressing ED length of stay, we are trying to both improve patient experience and improve patient outcomes. But we want to recognize we don't also want to impact access of care. So we have to sort of balance those things and want to continue to provide the important access that emergency departments provide. It's, you know, a huge success story in our healthcare system that everybody knows what to do and has a place to go in an emergency in most communities. So we want to address this issue holistically. We want to look at both operational changes that can occur in the hospital to impact not just ED operations, but hospital throughput. And let me make that clear, like, we get a lot of comments from emergency department administrators and staff saying it's not always us, right? It's not always us. And we do want to make clear that we understand this is more of a hospital throughput issue, and some of those issues extend to where we were discharging patients to, et cetera. So it's not even all within the hospital. So we, you know, need to focus both on reducing people who are coming to the emergency room who could be seen in other care settings, and trying to encourage health systems to make operational changes that can reduce boarding and improve this overall hospital throughput. So this slide just provides, you know, some of the things that the HSCRC has done historically to address ED wait times. It started with us trying to address the low patient experience scores that Maryland hospitals have compared to the nation. So we weight patient experience double what the nation does in our pay-for-performance programs. And again, as Jeff mentioned, you know, ED length of stay and patient experience are highly correlated. We also did things early on to try to identify particular hospitals that had longer ED lengths of stay and, request corrective action plans. And then we actually moved to directly incentivizing improvements in the outcome of ED length of stay by including ED length of stay in our quality-based reimbursement program. Unfortunately, CMS has slowly but surely discontinued the inpatient ED length of stay measures. And at the time, early on, there was a real push from the hospitals, and the commission agreed that we should be focused on inpatient and not outpatient length of stay. That is not the length of stay for patients who are coming and then being discharged to home or the community. And that was because we were asking hospitals under the all-payer model to do more care management, to do more to reduce readmissions, and to do more to sort of ensure that patients were getting the social services that could be provided as well in the emergency department. So we didn't want to focus on that initially, and so we focused on the inpatient side, which we again know is related to, again, the hospital throughput. However, those measures went away, and as I'll talk about in a little bit, we are in the process now of trying to develop our own ED length of stay measure in the state for inclusion in QBR this performance year. So it is back into the program for this year. And one of the things that I think this slide shows is that, we've done things over the years, but they've sort of been done individually. And so despite the fact that we've instituted these different things, we haven't seen much change. So currently, these are sort of the current and proposed interventions that we believe need to come together as a suite of interventions to really, a suite of interventions and incentives to really address this issue. And we've bucketed it here, the areas that we want to focus on. Again, reducing the number of people who show up to the emergency department. So trying to improve primary care access to ensure people who don't need to come to the emergency department can get care in a more appropriate setting. Then we talk about the middle bucket of improving throughput within the hospital. And then finally, we do recognize that we need, as a state, to improve the hospital discharge process and what resources there are in the community for patients, because we know that, again, getting the patients out of the hospital on a faster basis to the next appropriate site of care will improve overall hospital throughput. So the different initiatives that address these different issues are listed here, and we include things like the Maryland primary care model and incentives for primary care that, hopefully, showing Dr. Doherty's research, has shown that better primary care access should reduce emergency department length of stay. We also are in the process this month, actually, of having the commission weigh in on a policy for ED potentially avoidable utilization or multi-visit patients is what we're focusing on. And so that hopefully will also continue to, reduce the numbers of patients who are coming to the ED. And then within the improving the throughput bucket, we have things like putting the using our pay for performance programs to incentivize hospitals to improve on ED length of stay. So we have the QBR, or the quality-based reimbursement program, here on the top. And then we also have had our long-standing inpatient potentially avoidable utilization program. Then what we also will talk about here is our EDI, our emergency department dramatic improvement effort. And this process we'll talk about a little bit more, but this is a public reporting and performance improvement initiative that we're doing in collaboration with the Maryland Hospital Association, and was put forth by one of our commissioners in June and implemented with the help of the hospitals on a very rapid basis. Next, and we'll talk about this a little bit more, but we've also been tasked by our leadership, our commissioners, to develop another incentive around emergency department or hospital best practices. So things like, how interventions that we decide, and we're going to convene in the near future a subgroup to help us figure these out, maybe 3 to 5 interventions that we think hospitals should be doing in order to improve ED length of stay and provide an incentive for those structural or process measures. And then, we recognize that we have to collaborate with our public health partners at MDH. We need to address things like post-acute care, end-of-life care, and behavioral health. And, Jeff's research, again, slightly touched on this in terms of SNF access and other things that are influencing and probably responsible for some of the higher lengths of stay seen in Maryland. So briefly, I'm going to talk about the EDDI initiative, and my coworkers asked me if EDDI would be here today, and are always asking me about EDDI. But this was started again at the request of one of our commissioners, and it involves commission reporting on a monthly basis of 3 measures that of ED throughput. ED1, which is an inpatient measure, time of arrival to time that you go to your inpatient bed. OP18, that's the outpatient version, so the length of stay from arrival to discharge to the community. And also, through our partnership with the Maryland Institute for Emergency Medical, I get the MIMS.
Services system.
Thank you. We also look at EMS turnaround time through data that they provide us. This data we are getting on a monthly basis and is within a week or so of the end of the month for the previous month. And again, I want to thank all of the hospitals who have worked diligently to get us this data from the beginning of this initiative. I was personally concerned, will we get data? And every month hospitals have submitted it. We do say this is sort of preliminary data. It's unaudited and may change over time. So for example, the data is submitted for all patients and then also stratified by behavioral health. Hospitals are using whatever tools they have to identify the patients in those groups versus maybe using claims later on because it is so timely. The second part of the initiative is being led by our colleagues at the Maryland Hospital Association, and they have convened groups that are trying to do sort of rapid cycle quality improvement. And through that, as I'll talk about in a minute, they've all set goals for like the next 6 months. So small incremental goals that we hope can be built upon over time. And, we're hoping, and, MHA is convening the group to share best practices and share progress on these goals. So this is just a preview of what we present now. Every month at the commission meeting, we include on the left, you'll just see that it's the hospitals ranked in order of their average ED length of stay from June through the current month. And you can see the dots on the graph actually represent change from the current month to when we started this in June. We also look at the data by size of the hospital using the CMS hospital compare data. And again, this is because we recognize, as the work showed from Dr. Doherty, that larger hospitals tend to have longer ED lengths of stay. We don't see that as much here, a little bit, but we do see, within all groups, some very high ED length of stay, regardless of size. So in terms of EMS turnaround time, this again is made possible through data that MIMS collects, and they are looking at the time of arrival at the hospital, which the EMS dispatch providers capture, and then they're looking at the time the RN signs for the patient care responsibility, and the difference in that time. And, what they do actually for this is we're really just looking for high outliers. So they're looking at the time at the 90th percentile for each hospital. So what are the really long times that each hospital has, and can we make improvements over time on that? And so again, we report this monthly by just grouping the hospitals into these 3 buckets based on time, and then we highlight hospitals that have changed from the previous month. And again, we put this into every commission meeting packet, and then do a presentation to the commission on that changes a little bit over time and has different things that we might emphasize each month. As I mentioned, MHA is leading the Quality Improvement Initiative. All hospitals have submitted AIM statements, and again, all hospitals participated, and we, thank the hospitals again and MHA for this ongoing work. The goal was to set, again, some SMART goals, things that are achievable in the near term. And we are still looking for ways to sort of track how hospitals are doing on these AIM statements in a faster, more real-time kind of setting, because these aren't necessarily things that are wholly related to the outcomes we're looking at. They may be things like improving the percentage of patients that get discharged by a certain time in the day. And so that's not directly the outcome, but should influence the overall length of stay of hospitals. Oops, I'm on the wrong slide, because I'm not keeping up, I apologize. So these are just examples of some of the AIM statements. And again, some of the hospitals are looking at, the outcomes like OP18. Some of them are looking at other more intermediate outcomes that they can improve operationally. So next, I just want to talk about the quality-based reimbursement program. We have added, as I mentioned, ED length of stay for calendar year 24 performance. But right now, we don't have a measure for it. This just shows that the weight of the measure in the QBR program, it is weighted at 10% of the overall score, which statewide is about $22 million is at risk for either rewards or penalties based on performance on this measure that we are in the process, of developing. I keep not keeping up. All right, so this is the, we've currently convened two subgroups that are helping us develop this ED length of stay measure for inpatients. We had our first meeting last Friday of the data group, so they're responsible for coming up with how are we going to collect this data from hospitals in a timely manner. And then the second subgroup will then say, what is actually the measure? So are we looking at the inpatient people that are non-psych, or are we looking at all? We will talk about whether there needs to be any risk adjustment to the measure. And then also, what is the incentive? So is the incentive focused on improvement only, or is the incentive focused on giving rewards out for hospitals who are already performing well? I think that, from our point of view, previously we just did improvement only because we felt everybody had room to improve. But those will be discussions that we have as we develop the measure, and then we will take the work back to our performance measurement work group for sort of the final advice before we take it to the commission. But again, this measure is in this year's performance, and so we want to make sure that even though we don't have the exact measure, it is focused on inpatient, and obviously improvement for sure will be part of this. Whether it's improvement and attainment is yet to be decided. So in terms of the data collection, the meeting we had on Friday reviewed some of these options of potential ways we could collect the data. The first and the most preferred option is for us to get timestamps added to the monthly case mix data that hospitals submit. This is preferred because then we would have patient level data to do not only the overall measure, but also do things like look at disparities in emergency department length of stay, or by different factors, or be able to drill down and understand where there are some opportunities. If we can't get patient level data, we could use something like the EDDI process, where hospitals are submitting summary level data to us directly on the measure. For this, we would want to develop some, more definitive specifications for the measure. There's some concerns still about whether hospitals are consistently reporting observation cases, for example. And we would want to be able to sort of do some quality assurance on the data. And then last but not least is there has been electronic clinical quality measures, or ECQMs, for both ED1 and ED2. Now, CMS has discontinued those measures as of calendar year 24, but the specifications still exist. And so while this might not be a solution we can do in the near term, in the long term, this might be an easier way to collect patient level data than adding the timestamps to the case mix data, and be we could be more assured on the universal specifications of the measure if we were able to use the ECQM infrastructure. But right now, we're early in our venture into collecting ECQMs, and some of the EHRs, aren't willing to make the adaptations that might be needed to continue to collect these. So the other initiatives that were on the chart, again, included the work on the multi-visit patient policy. That, again, is going to come to the commission in February for a vote. And this is a reward-only, improvement-only program. So we're looking for hospitals to reduce the number of visits that people who are having 4 or more visits to the hospital through the ED. We're trying to reduce that, and hospitals that are able to do that can qualify for this reward. And then, as I mentioned, we've also been tasked by our leadership to develop an ED best practices incentive. And I guess I would say that while it has ED in the beginning, again, I think this is more of a hospital best practices incentive. And we will be looking for help in figuring out what those universal best practices should be. So we will be putting out a call for volunteers and to help us with that work. And then last, as we talked about, collaboration with MDH to address some of the broader policy issues around SNF access and behavioral health and end-of-life care. So, just in closing, we recognize that there are challenges in Maryland, and these challenges in ED length of stay have existed even prior to the global budgets. But we think that we have a unique opportunity under the total cost of care model to have both hospital programs and statewide policy that can be used to improve both how patient experience and ED length of stay. And then, as this audience, very well knows, the hospital global budgets determine a hospital's revenue, but not necessarily how those funds are spent. And so, we pose the question of, are there ways to reallocate dollars towards programs that would improve, again, hospital throughput or ED performance. And then, we do think that overall, this working on this issue and addressing this issue really is in all of our best interests as potential patients. I recently had to actually send my husband by ambulance to the emergency department. He'd broken his ankle. And when I said, okay, I'll follow in the car, the EMS provider said, you're not going to be able to see him for several hours. You might want to wait. And I called this a occupational hazard. I proceeded to go back to bed, and I didn't turn my volume on my cell phone up. And so when my husband came through the door with a cast, having Ubered home because I didn't go to meet him, I had to apologize and say, I look at this data every day, and I thought you'd be there a couple more hours. So we all will benefit from this work. But last, I really take very seriously what one physician said at the MHA task force. And that is that we went around the room and said, what would success look like for this task force? And this one physician stood up and said, it would be people wanting to go back in to emergency medicine. And I really take that comment to heart when I do this work, because We depend on these people, and right now, staff well-being, whether post-COVID in particularly, is at an all-time low. And so as we think about how we can improve this, I do think we need to keep both the patients in mind as well as the staff, the doctors, the nurses, the other staff who work very hard in the emergency departments, and want to do the work that they're doing and provide an important public health service and access to critical care. So with that, we will pause and go to our person with the mic to answer any questions.
Questions,
Thank you.
questions for the person with the mic.
Thank you, James. That was a great presentation. I had a question, and you kind of alluded to it at the end, Allison. We're all consumers as well as, our day jobs. And I was talking to Brian Sims about this. It's probably been several months now. I had an experience where I was in multiple EDs with multiple family members and could not get over the differences. And, if we have that type of feedback, I'm a question asker, but I'm sure they love all the questions that I'm asking. But, if we have feedback like that, does it make sense to funnel that like through MHA, through HSCRC? I'm not clinical, but I've worked with clinicians since '97. So again, just curious about that.
I think that we'll take the feedback however you want to provide it. I mean, MHA, I'm sure, would be open to it, but we are as well. So please do write us. Do tell us what your experiences have been. I think as we go into this development of what are some best practices, it would be great to identify some of the high performers that patients really feel met their needs in a timely manner. And so please do reach out to us, and we welcome any and all input.
Thank you.
Other questions?
Thank you. Thank you for your presentation. It was very insightful. My question is, in one of the bullet points here, you make reference to hospital GBR determines revenue, but not how funds are spent. Certainly that makes perfect sense. And what I'm thinking is, to the extent that you want to, or the commission wants to incentivize hospitals to invest in this, has there been any thought given to increasing the safe harbor that's available through revenue for reform? Because right now it's largely medically underserved areas and healthcare provider shortage areas, and setting up services there. If investment opportunities exist under revenue for reform to safe harbor some revenue at risk, maybe we would see more investment in the areas you're describing. So I'm just curious if revenue for reform will increase its scope in terms of safe harbor provisions.
Great question, and I do not want to say that I am a revenue for reform expert, but what I will say is I think the policy will evolve. I think we've started with some of the inefficient hospitals, but I think the original vision was for it to be broader, and I think that, again, population health initiatives that are going to address some of those buckets, I think are absolutely could be, in the scope, and it's a good suggestion, and so we will make sure our colleagues who are who work on revenue for reform are understand that, given the level of this issue.
Other questions?
While you're looking for the next questioner, I think I would also maybe add that it's important to know that we conceive of this as a problem with a lot of different solutions, and I think not all of them necessarily require additional revenue, right? So there are, I think, some gains in hospital efficiency that would potentially be, like expenditure, neutral or beneficial, and also potentially have a desirable effect on ED performance. So if you think about relationships with SNFs where you're doing something like telemedicine, where you're reducing the incoming SNF volume and also making sure that there's beds available on the backside to discharge patients in an efficient manner, that could actually ultimately result in a reduction of expenditures as well as increased ED throughput. So just a thought.
Hi, doctor. So I was just having a follow-up to the gentleman's question over there. He said, that I guess to increase the scope of the safe harbor and include maybe some of these non-rural areas. And your answer was, we're looking at some inefficient hospitals. And I'm curious, how do you identify those?
Another great question, and one that my colleagues could answer probably better than I do. But there are efficiency methodologies. I can't talk to the details of them. I can point out to you who can, but I think what my reference was to that the initial revenue for reform policy was open to those hospitals that were identified through our methodologies as inefficient. But I think we see it long-term as a larger policy potentially. So happy to point you guys in the direction of who knows all the details on that. But again, I think that it's starting right now with some of those hospitals that were identified as inefficient so that instead of having to do a spend down, they could get credit for these investments. But long-term, I think it was originally envisioned as broader and applicable to all hospitals.
Good morning, emergency department provider. So I appreciate and really respect the HSCRC to take this issue on. And the methodology that you're proposing is certainly valuable to think through how the canary in the coal mine, our emergency departments, are being addressed. So well done on starting this conversation. One question I had for you, and I think that there's real value in, is the point, and I wish you could elaborate a little bit on the ED best practices. And that initiative the HSCRC is coming on. I don't necessarily think, or let me just rephrase that, I think there's opportunity to share best practices of what we're doing now. But really, I think where the value could even be further is the skate where we're going, is what are the innovative models that we could and should develop that are not necessarily employed right now, that where healthcare needs to go in the future. So I hope the best practice model of how HSCRC is thinking about it really embraces both.
Excellent point. I sort of, while we want to learn from other hospitals potentially or in the state or the nation, there may be things that nobody's doing in Maryland that we should be doing. And absolutely, I think that what we need are experts to come and help us identify those things. And again, it's these are more of the structural and process things that hospitals can't have more control over than the outcomes. So we're trying to go for those intermediary kind of process and structural things in addition to the overall outcome. So thank you.
A pretty interesting part of the emergency department is that we have no idea when the patients are going to show up. And so everything we've been talking about has to do with the internal process and how we can improve that internal process. I think there's a bigger question on how do we get our patients to understand different alternatives and how do we bring that to them. Certainly the insurance companies have tried to do it in some little bit of ways by changing the amount of the copay, but certainly that has not actually worked. And so as part of this process, are we going to talk about the other side, the demand side, the patients that are coming in, and how do we re-educate them on a process?
Yeah, so great question, thank you. I think this is the dynamic that is directly addressed by the multi-visit patient policy that will be going into effect shortly, we think. So the idea there is to address exactly that idea. Are there patients who would be better served in care settings other than the emergency department, and what can we do to get them to those places instead of the ED? We worked with hospitals to develop the policy, and the feeling was that they don't necessarily have a good handle on somebody who shows up once in their ED, and that person's not really somebody that they're going to have a huge opportunity to work with to emphasize different behavior. But somebody who's in the ED 4 or more times is somebody that you're going to be seeing pretty regularly, and you can work with them to get them pointed towards different care settings and services that may reduce their ED visit rate in the future. So we are at this point fairly hands-off in terms of the specific interventions at the hospital level designed to achieve those goals. And that's for a couple of reasons. One is the policy applies ED-wide, not just to specific types of patients. So some hospitals may feel like it's going to be most impactful for them to work with behavioral patients, while others may feel like it's folks at end of life or with significant social needs. And so we didn't want to prescribe interventions in that regard. But yeah, I think that policy will hopefully kind of take some of the pressure off with those types of patients.
Allison, Jeff, thank you so much for your presentation. I knew all I needed to do is threaten you all, and you all would start asking more questions. Keep it up. All right. Like I said, I'm really excited about this next presentation. This presentation, I think, could directly reduce your consulting spend. I think that's a promise I'm gonna make. So we have two great speakers today. Tanisha Lum, who's the Associate Director of Reporting and Analytics at CRISP. She oversees CRISP report development for the HSCRC quality and methodology programs and leads a variety of projects in support of the total cost of care model and the SIHIS. Prior to joining CRISP, Tanisha was intern at Alidad and AmeriHealth Claritas in Pennsylvania. She has a BS from Boston University and received her MHA from GW University. Claudine Williams is joining her. She's the Director of Healthcare Data Management and Integrity at the HSCRC. In this role, she directs the team that's responsible for the collection, the aggregation, the auditing, the questions, the dissemination, the approvals, all those good things around data. So she's also responsible for activities related to the acquisition of external data sources and interagency data integration, which is pretty darn cool. So please join me in welcoming Claudine and Tanisha.
All right, good morning, everybody. Thank you for having us. So we're here to talk about all the data, or at least all the data that's available through the HSCRC and CRISP. So let's go ahead and get started. So first I will talk about the data that you can get from the HSCRC, the process to request that data, and then I'll turn it over to Tanisha, who will go through some of the data that's available through the CRISP CRS portal. So there's several different types of data sets that you can get from the HSCRC. So they come in three main types. We have statistical aggregated data, we have non-confidential public use files, and confidential files. So when hospitals or when requesters approach us, we try to direct them to the first two options, the statistical or the non-confidential, because it tends to take less time. The third type of data takes a little longer just because of the sensitivity of the data. And it is our duty as custodians of healthcare data to only provide what's minimally necessary. So what's on this slide is about the statistical aggregated data, which are custom data tables that are based on our case mix data and are best used for basic analytics. So for example, the number of ED visits for gunshots by county and by race. Cell suppression for observations under 10 will be applied unless you get permission from the HSCRC to have small cells. And if the request is complicated or the staff does not have the bandwidth, we will punt this over to our data processing vendor, and processing fees may apply. All right, so the next type is our public use file. So there's 4 different flavors, like, ice cream. We got the basic, we got grouped, we have the revisit, and the EasyMed file. So I'll go through each of those various data sets. They are all patient level data sets that contain limited demographic, diagnostic, and charge information. The difference between the basic and the more grouped, revisit, and EasyMed files is that they're value-added variables from the 3M groupers, so that's your APR-DRGs, your EAPGs, and your PPCs. And those are included in our grouped, like I said, the group revisit and the EasyMed files. And the flavor of data you want really depends on what you're looking for. So for more basic analysis that doesn't require the group variables, the basic file should be fine. If you need something more advanced, then the grouped or the revisit files would be more of your flavor of choice. And please note that all the group data uses the version of the grouper that the HSCRC designates. So it may not necessarily be the most recent or the newest version. So the revisit file is similar to the group file, that it includes the value-added variables from the APR-DRG, the PPC, and the EAPG, but then it also includes specific variables to be able to track a patient across time, across hospitals, and across settings. So this data set, the revisit data set, is limited to researchers or internal analysis, so it's not available for commercial use. And the last one here, the inpatient equivalent case mix adjusted discharge, is a very big title. We usually call it just the EasyMed file. It's similar to the group file, but it includes additional logic. So it moves like the outpatient observation stays greater than 24 into the inpatient data. It provides the EasyMed assignments and other key variables used in the calculation of market shift, which I'm sure many of you are interested in. So then we also have our market shift data sets, and these are more policy-specific data sets. So this is including our market shift file, our case mix weight file, and the uncompensated care. So these are more specific to particular HSCRC policies, and these data sets are used by the industry and interested stakeholders to validate our policies and to model hospital performance on particular areas. So this just shows you the last policy-specific data set, which is the uncompensated care data. All right, so we do, on occasion, provide confidential data sets to users. Now, this is very limited, and it's usually limited to research and internal projects such as process improvements or pre and post interventions research for a patient panel. So a hospital can submit a patient panel, usually through CRISP, and have access to some of their confidential information. Hospitals can also receive their confidential data set, so for their hospital or their particular system, and share it with a consultant working on their behalf. They would just have to submit the request to us. So now I will go through the process to request this information. So there are several entities involved in the review and in the process of case mix requests. So all the requests are reviewed by my staff, my team at the HSCRC, so we make sure it's complete, we make sure it makes sense, and then we continue in it, and we also make the final decision on the release of the public files. We also have a HSCRC review board, so this is an external group of researchers and users of our confidential data, and they provide us they provide review of all the confidential data requests. So they make sure that it makes sense, that the research question is viable, and then they recommend either changes or release of the confidential data. We also have the Maryland Institutional Review Board. They are the ones who review all research projects. They also are the ones to make a determination for a waiver for IRB waivers. So if you are submitting a request and it has research in the title, in the name, somewhere in the description, it is going to the IRB. All right, so I'm sure many of you who have requested data from us have heard of the Maryland Strategic Data Initiative, the SDI. This is a newer group that has formed within MDH, and their whole purpose is to make sure that the data, that Maryland state data that's being released outside of our organization is being stored and assessed appropriately. Their review could take a month, 2 months, so we really try to build that into the review process, but all the requests have to go, except for statistical requests, all requests must be approved by the SDI. We also have our HSCRC commission, so for confidential requests that go through all the prior reviews, it gets approved at our monthly public sessions, so they make the final approval for all confidential requests. And then lastly, CRISP, if they are involved in any EID matching or with the panel research projects, the request also needs to be approved by them. Okay, so to request statistical analysis, we have an online data request form through Dave. I don't remember what that stands for, so we're just going to leave it be. So most of the hospitals are aware of Dave. This is how you get your error reports, but this is also how you're able to request statistical data. So once you register, so this is the registration page, then you can go and complete the request right online. We ask that you make sure that the entire thing is complete and that you also include a table shell, so let us know exactly what your output would like to be. It makes it much easier and it causes less questions for our staff. And then it goes through an internal review, as I said, and then the data is processed. If we're unable to process it internally, we may punt this to our data processing vendor, HMetrics, and if they run it, it's usually, there is a cost. Okay, so some reminders for submitting data requests to the HSCRC. So use the most recent application. So there has been so many times we've had to kick things back to the requester just because they're using an old form. Make sure you're using the correct form. So for statistical requests, please use the form that's through Dave. For the non-confidential public use files, we have the most recent data request application on our website, so please check our website. And then for confidential requests, please reach out to our staff, Oscar or Curtis, who's sitting right over there. They can make sure that you get the most recent application for that. So once you submit your application, make sure that you put it on your company letterhead. If you put it on our letterhead, we're not going to take it, because obviously we're not requesting the data. So we want to make sure it's on your letterhead. Make sure it's complete. Again, if it's missing information, if you didn't complete all the data, security questions, it's going to get kicked back and it's not going to get processed. Also, for the statistical request, make sure you clearly state what you are looking for, your desired time periods, your target population, all that important information, because otherwise we'll be coming back to you with questions and that just extends the processing time. If you are a consultant working on behalf of a hospital or MHA and you're requesting data, you must, absolutely must, have Appendix 3, which is the release form. You must have that signed from the hospital or from MHA to say that you are working on behalf of them. 3M has put on us very strict guidelines on whom we can share the grouped information with, and so we are only allowed to share it with Maryland hospitals. So if you are working on behalf of Maryland Hospital, you'll need to have this form signed. And then finally, there are processing fees for the public use files to process those files. So once you submit your request and it's approved, our data processing vendor will reach out to you with an invoice for how much it will cost. All right, so the level of approval depends on on the type of data requested. So as you can see here, for the statistical request, it only requires an internal review, so that's the quickest. For public use files, it requires an internal review and the SDI, so that might take a little longer. For hospital-specific confidential requests, it only requires an internal review and SDI, but for the confidential, it requires all the review. So understand that if you are requesting confidential data, it's going to take longer. All right, so this is a quick graphic on the timeline and the process for requesting statistical analysis. So as you can see, it starts with the request, it goes to HSCRC review, it gets approved, we process it, you get your data. Takes about 4 weeks. If it's done internally and we can turn around quicker, it could take about 2 weeks. If it requires additional input from our staff, like our quality team or HMetrics, it could take up to 4 weeks. Now, for data requests for confidential and non-confidential, it's obviously much longer. So once your data has been requested, the HSCRC does an internal review. If it's a non-confidential, it slides right across there to the SCI and then slides right across to the approval. Now, if it is a confidential data request, it has to go through internal review board, it has to go through IRB, it has to go through commission approval, it goes all the way around. So again, it takes a lot longer. So for public use files, it could take about 90 days. For confidential files, it could take about 120. All right, so at this time, I will turn it over to my colleague Tanisha, who will talk about CRISP data. Tanisha.
Thank you, Claudine. And I'll begin by talking about what is CRISP, because even folks at my table didn't know who we were. But to know is to love us. So, CRISP Shared Services powers a technology that serves as a state-designated information exchange for Maryland, West Virginia, D.C., Virginia, Connecticut, and Alaska. Our vision is to enhance health and wellness by deploying health information technology solutions adapted through cooperation and collaboration. To do this, we begin with a manageable scope and strive for incremental progress, cooperate with other healthcare organizations, promote consumer control over their own health data, and use best practices and standards to serve the entire community. In 2022, CRISP was designated as Maryland's state health data utility. The purpose is to collect, aggregate, and analyze clinical information and public health data to assist the department, so Maryland Department of Health, local health departments, and the HSCRC in the evaluation of public health interventions and health equity. A little bit about CRISP. CRISP has 5 core services, the first of which is our point of care tools, where providers can search for their patient records such as labs, immunizations, and radiology reports. They can also view other members of their patient's care team, care alerts, and monitor the prescribing of PDMP drugs. Next is our care coordination. Our encounter notification service, where providers opt to receive notifications for their patients to follow up after they are discharged from the ED or inpatient. Third is public health, so that's our CRS, and we'll go deeper into that in the next slides. Fourth, our support for public health. We support various initiatives to support Maryland Department of Health, such as sending MDH alerts for tuberculosis, Legionnaire's disease, and antibiotic-resistant diseases. We also helped FQHCs with their Medicaid redeterminations. And then fifth is our program admin, who runs our CRISP learning system to facilitate the dissemination and adoption of best practices to enhance knowledge, sharing, and collaboration. They also work very closely with the HSCRC on the care redesign programs. Now let's dive into the population health reports. That's the fun stuff. Not that everything else is not fun, but this is the best stuff. So the population health reports, better known as CRISP Reporting Services, or CRS, is found at reports.crisphealth.org. Users run the full gamut of the healthcare community, from hospitals to long-term care facilities, and regulatory users such as MDH and the HSCRC. Each user is allowed to access various levels of data. So some users can only access summary level, while others can go down to the patient level. Report access is managed by your CRS point of contact. These reports on the tile are on the report are broken down by tiles, and one of the tiles is HSCRC. The HSCRC tile houses the reports supporting the HSCRC methodology and quality programs, and this is powered by the case mix data. Use cases for these reports include tracking and trending performance in HSCRC quality and methodology programs, including each component of the program, estimating reward and penalty for those quality programs, as well as identifying patients who contribute to performance measures for each program to identify areas of opportunity. These reports are for every quality program, and depending on your level of access, you can view your hospital-specific summary data or individual patient-level data for programs such as the QBR timely follow-up and the ED the ED measures. Shown here is the Quality Financial Impact Dashboard, which is my favorite report. This gives high-level insight on hospital-specific performance and the quality programs as it relates to the dollars. So here you can see your performance coupled by your expected reward or penalty. We'll be adding the quality or QBR to the QFID in the spring, and we hope to expand to other non-quality programs soon. Another set of reports are those that support other total cost of care programs. These reports are housed in the Medicare population and the MDPCP reports tile. Use cases for these reports include serving as a singular portal for program enrollment, performance tracking, incentive payment reconciliation, participant comparison tools, predictive tools to identify the likelihood of avoidable hospital events, and identifying disparities within and across demographic groups and utilization and payment for attributed MDPCP beneficiaries. These reports are powered by the Medicare CCLF data as well as HSCRC case mix data. Picture here is the MDPCP reporting dashboard that helps MDPCP practices navigate throughout the reporting suite. Also in the Medicare tile is our Medicare data analytics engine, MADE, powered by CCLF data. This is one of our largest suites of reports, and use cases range from viewing patient-level information for MPA attributed beneficiaries, comparing beneficiary spend by claim type, and identifying hospital-specific discharge patterns to post-acute facilities and assessing the performance in readmissions, length of stay, and payment. The MAID suite has reports covering many categories of healthcare, from pharmacy to skilled nursing facility. Here is a screenshot of one of the episode-based reports. Another tiles are all payer tile. Use cases for these reports include viewing total patient visit count and charges, analyzing and comparing total hospital cost for a subset of your patients, and view and compare hospital utilization for attributed beneficiaries against a reference group. These reports include case mix, CCLF, and Medicaid data. You can also drill down to the patient level if you have access. The multi-payer reporting suite is our newest of our CS reports and is pictured here. This report helps set Maryland up for the goals of the AHEAD model because it pairs Medicare and Medicaid data. The screenshot here of the report shows the usage of prenatal services and couples this with data with gestational age at birth. The last tile we'll go through today is our public health tile, and this is summary level and utilizes case mix data for these reports. Use cases include evaluate the impact of community health needs assessment, evaluate impact of community health investments, monitoring individual hospital and statewide progress to fulfill the CIHIS goals, and identifying disparities in care and encounters. Pictured here is our SDOH report showing income per capita for the state of Maryland. So I know I went through that super fast. I don't like presenting the reports. I rather just demo it to you and ask and answer any questions that you have. So on the CRS portal, we have an extensive list of all our reports and user guides. If you have any questions, please let us know. We are happy to assist. Some reports even have live video demos that we did and are available on the CRS portal and the CRISP learning system. We pride ourselves in being consumer-centric, so if you have any questions about a report, want a demo, or would like to provide feedback, please email us at support-at reports-crisphealth.org. As I mentioned, we're adding QBR in the spring, so if you want to give feedback on that report before we release, please email us, and we'll open it up to questions.
How many of you, raise your hands if you knew all that was available to you? Oh, you're full of crap. Every one of you walking out of this room should send an email to that box and have a demo. I've sat through it. You'll be amazed. It'll be like, well, can you do this? Oh yeah, we can do that. Well, yeah, but can you do this? Yeah, we can do that, right? So like that's been my experience, and Tanisha and the team are great. So, questions?
I was going to say that they want to get to lunch.
Wow, they haven't earned lunch yet. I'll be the decider of lunchtime. What questions do you guys have?
We're just very clear.
Tanisha, what of the reports and the modules and the tiles that you have, which ones are the most utilized and which ones are the most underutilized?
The most utilized, I would say, are MDPCP reports. Practices are in those reports multiple times a day, looking at everything. The underutilized report, I think, is the Quality Financial Impact Dashboard. People don't really know about it, even though we promote it a lot. And then when people see it, they're like, oh my gosh, this is great. So please utilize that report. It links out to all of the HSCRC quality programs, and it's beautiful.
Beautiful.
No, you don't think it's beautiful? I can go back and show you.
I'm the biggest fanboy that's in this room, I think. What about like the market shift reports? Can you talk a little bit about what's available as it relates to market shift?
I will gladly punt that to William Henderson if he wants to talk about the market shift reports. Market shift reports, we post them twice. They're not as beautiful because they're static Excel-based reports, but they house a lot of information. We do the 6-month market shift and the 12-month market shift. Things are even broken out by area of the hospital, so take a look at that. Service line, that's what it is.
I believe there's easy meds in there. It's a ton of information that we put out through CRISP, so we highly encourage folks to use it.
How many of you need ECMAD and market shift reports to do your budgets? Anybody? No? Nobody? Yeah, you're full of
And we just updated it last month.
Yes.
Very.
Can you comment on whether there would be any plans to have any of commercial data? I know you have Medicaid and Medicare now. Is there anything around commercial data that could be expected at some time?
Yeah, I can't give a date, but we're hoping to include commercial data soon or in the future in our multi-payer reporting suite, which right now only has Medicare and Medicaid data.
Can you talk about frequency of when reports are updated and a little bit about your process of, reconciliation and kind of getting validity and accuracy of the data?
For which reports? So typically, our HSCRC quality reports are updated on a monthly basis. Public health dashboard, I didn't show that, it's also on a monthly basis. In terms of reconciliation, depends on the data source and the purpose of the report, but we do validate our reports extensively, and like I said, we're open to feedback. So if you think the report is wrong, we take that very seriously and we look into it.
Great. Other questions? All right. Thank you very much, ladies. All right. So we're going to start our afternoon talking about the annual filings. I know it's not the fall. It is the winter. So we're going to actually talk about annual filings early this year because there's some big changes potentially coming down the pike with the annual filing. So Beth Kelly, you can start freaking out right now. We have two speakers. I love you, Beth. We have two speakers today. Karen Teague, who has been with the HSCRC for 6 years. She's the Associate Director in Medical Economics and Data Analytics, leading a lot of the analytic efforts within the HSCRC around financial and rate modeling. She's joined today with Bob Hecox, who's founder and partner of the Maryland-based consulting firm I3 Healthcare. Bob has been a longtime member and supporter of Maryland HFMA. He's probably been to a few annual conferences. We won't speak about them, though. And over his 45-year career in healthcare finance and operations, Bob has worked with nearly every hospital and health system in the state of Maryland. So please welcome Bob and Karen.
Thanks. You left out the most interesting fact about me is that I have a pig. Her name is Charlotte, and she's very large. So now that you woke up, this afternoon we're going to be providing you an overview of the annual filing modernization project and just kind of giving you a sense of where we are and some upcoming timelines that might be of interest to you. So this is our agenda. We're going to quickly talk about where the project is with the where the filing is with the HSCRC today. Spend the bulk of our time talking about the project overview before talking about how opportunities for hospitals to engage with the project and then some next steps. So the annual filing is one of the most, if not the most important pieces of data that we collect. It's really the core methodology of, it's at the heart of just about everything the HSCRC does. It informs hospital rate setting. It affects our methodologies, for example, the efficiency policy. And it really gives us a sense of how hospitals are doing operationally. But I think most of you can agree that as it stands today, it's pretty antiquated. And it's not a function of, how it was built. It's just a fact of the ever-evolving nature of the healthcare industry. And we've been talking for a while now about maybe updating this piece or this piece, but the filing is so interconnected that we were really hesitant to kind of work on it piecemeal, which leads me to the annual filing modernization project. So the goals of this project are to modernize policies and templates used for gathering data on clinician costs, population health resources, and various cost centers, to revise the cost allocation framework, to assemble a comprehensive web-based tool for submitting your filing, and to review and update the accounting and budget manual. The annual filing is technically a 3-year project, but we anticipate that the majority of the work is going to be performed within the first 2 years, with the 3rd year really serving as a buffer year in case of unforeseen circumstances or problems. The success of this project really kind of hinges on the participation of Maryland hospitals. We really value your input, and so we will talk about opportunities for how you can engage throughout this presentation. And finally, we're extremely grateful for the knowledge and expertise of our external consultants like Bob, I3 Healthcare Consulting, Mathematica, and SB & Company. As you can see on this slide, we've broken the project into 3 different subgroups. We're going to spend the majority of the presentation today talking about subgroup 1, focusing on clinician costs, so physicians, physician assistants, nurse practitioners, the indirect cost centers, and the overhead cost allocation. But I really wanted to just give you a brief overview of the other 2 subgroups. So as many of you know, the hospitals are able to submit their annual filings to the HSCRC in 2 ways. They can either submit populated data in our Excel model, or they can submit the output schedules to us. And we really kind of wanted to move to a centralized, standardized, application. And so we are going to develop an e-tool for hospitals to use to submit their data. We are in the process of soliciting and are sending out an RFP to solicit a vendor to help us create this. We expect the RFP to go out in the coming weeks. And really, the only thing you need to know about this is it is not going to affect your fiscal 24 annual filing. We don't expect this to go into effect until fiscal 25. So stay tuned for more details on how you can engage in this. And then subgroup 3 is focusing on revising the accounting and budget manual. There are just some things in the manual that might be out of date or no longer used, and it's going to have to get updated for all of the changes related to subgroup 1. And in addition, many of you know their accounting and budget manual as it stands today is not very searchable or user-friendly on our website. And we really want to change that. So we are looking to find a way to make it, searchable at the very least. So stay tuned for more opportunities for that. But now we're going to dive into the focus of our presentation today, which is subgroup 1. So focus on redefining what we collect for physician costs, expanding our indirect cost centers, and revisiting our overhead allocation. So hospital and physician relationships have really evolved since the beginning of the annual filing. We recognize that on some level, hospitals are subsidizing physicians, and if we could better understand that relationship, it would really allow us to better enhance our methodologies. So for example, in the efficiency methodology, we are not allowed to fund physicians, and so we strip out all profit despite knowing that hospital margins subsidize physicians. And Alan is interested in exploring if and how we could potentially create a physician subsidy within the efficiency methodology. I mean, maybe we can't, but it's not even an avenue that we're able to explore within the structure of the data that's currently collected. And the indirect cost centers and the overhead allocation really kind of go hand in hand. So hospitals are really focused on expanding their population health initiatives and care management, and we really need to update the indirect cost centers to more closely align with what's happening at hospital, which is going to shift costs. And when costs shift, so is the overhead allocation. So they really kind of go hand in hand. In addition, we really want to focus on the overhead allocation. We've wanted to look at it for a while now, especially in regards to supplies and drugs. We know that, or we believe that the overhead for supplies and drugs is really high. But is it too high? And if so, how do we fix it? If you were just to assign an arbitrary amount and say 10% of overhead should go to drugs, the rest of the overhead that was there would get shifted to all the other rate centers, which would have massive downstream implications for rates across those centers, and we have a duty to keep rates reasonably related to cost. So it's not as simple as just kind of assigning an arbitrary amount. You first have to really dig into the data and understand what's happening in the methodology. But I really want to stress that when we talk about overhead allocation in regards to this project, it's not specifically supplies and drugs. That tends to be what people think of when you talk about overhead allocation. And it was just kind of used as an example to explain why it's so important for us to first dig into the details and understand what's happening before we can potentially model some solutions. With that, I'm going to turn it over to Bob.
Good afternoon. Karen's laid out the overall methodology, and just so that we kind of keep everyone in context, the first step of that methodology deals with looking at fundamentally cost centers, and one that largely doesn't really exist in the annual filing today is what we have labeled clinician. Others might call it advanced practice providers, but it's fundamentally those that are at the front end in terms of being able to bill and collect and deliver care and direct care. So we're looking at that under the label of clinician. So as I use that phrase in this process, I just want to make sure everybody's on the same page. What we're looking at are three different sections of the annual filing with a mind towards How does it relate to today's hospital environment? The modernization is critically important so that we make the annual filing more reflective of what's really going on and how it's termed in the current hospital. And that as we move this process forward, we are going to initiate it with a survey, which I know you all love. That survey is expected to create a foundation. The good and bad news of that is that when I say foundation, the good news is it doesn't require a single financial, there's no dollars involved. So it could be a first for the HSCRC. But it does require a lot of evaluation for each hospital. And what we're looking at are basically what are the roles that physicians currently play within the hospital environment. Back in 1979, I started my career, and one of my first projects was to work on this annual filing. It was not on either of the tools that Karen described. It was a bunch of catalog of paper. The accounting and budget manual was somewhat unchanged from that point to today, honestly. There are some pages in there that were drafted, I'm sure, before that year. And as it progressed, the role of physicians has changed dramatically. In 1979, there were no hospitalists. There were no intensivists. The people that actually provided that care were the PCPs and specialists in the community who came to round on their patients. That was not an effective tool for managing length of stay, and as a result, over the years, we've adopted a policy or practice of putting physicians with a role inside the hospital to manage that patient care. And as a result, we have literally in each hospital hundreds of relationships that have been born out of that. And what we're looking to do is to begin to describe what are all those relationships and who are the physicians, not by name, thankfully, but who are the physicians and what kind of relationship does the hospital create in order to manage that. So as we gather that, what we're looking for is to set the scope of how much of this activity is there, how much physician relationship exists to run the hospital. And then once we know the scope, we'd like to understand the beginning of scale, because there are some relationships or some roles are very limited, and we probably won't put them at the front of the line in terms of how we're hoping to move forward with building up what ultimately will be a set of new reporting that will be part of the annual filing that will maintain a summary and a detail of here are the physician relationships and here's how those subsidies come about, or here's how that relationship has morphed over time. So the end result of this is an additional dimension to the annual filing. The process to get there, though, is going to be a progressive one. We're going to start with the survey as a baseline, a foundation, and then we're looking for all those people with their heads low right now who are the annual filing, really the people that know it, understand it, and really can evaluate it. We want them to join us in a work group. While we all have experiences, we want to get interaction going to create what is the annual filing of the future, particularly as it relates to physicians at this point. And what we're looking for is input that will help us to discern where those areas of exposure are and how we will be able to gather data that will help us to evaluate the risks, and that the commission ultimately will gain the information that they need to proceed with new policy with regard to, rather than ignoring the cost of physicians, for the large part, to actually becoming a proactive participant in it. Okay. So we have a survey that, am I allowed to? We have a survey that starts this process. That survey hopefully will be moving out to all of you, or to some of you, to all of your hospitals tomorrow. And that survey we hope that you will take very seriously, and in our custom, we will be asking for that to be your first entry into this process, but we hope that your entry will last for several months ahead as we begin to formulate that schedule of the future. The other areas that we are interested in, but have kind of put on a parallel track that's moving slower, is the cost center definition. And it deals mostly with the overhead costs. And what we're trying to do there is to take off not every cost center in the annual filing, but to take off some of the key ones, the top dozen or maybe 20 at the most, and look at those specifically towards, does the cost center actually depict what is operating in today's hospital? And what will be easy to kind of give you as an example is, if you think about the different parts of the cost of the annual filing, there's one that has a very significant role, and it is a cost center unto itself, but it's a process unto itself, and it's called data processing. Has anybody here in the room ever worked in the data processing department of a hospital? Didn't think so. In 1979, there were lots of people working in data processing, and they used punch cards and magnetic data tools, and the infinite changes that have occurred in that area are not even discussed, mentioned in the accounting and budget manual. So it leaves it to everyone in this room, or everyone dealing with the annual filing, to make an interpretation of those issues and decide where that cost should be. And quite honestly, from 1979, I got to do the annual report for the same organization for 3 straight years. And what became the rule that I used in years 2 and 3 was, how did we do it last year? And that is something that we're trying to move away from. So we're trying to make the budget manual as specific as we can make it for today, with the knowledge that we need to continue to maintain that and move it forward from that point in time when the modernization ends and life in the normal world will continue. So we're looking at that as a very specific effort, and related to it, the allocation methodologies that occur for each department. There are a lot of them that are in common. Some of them are very unique. Counting the pounds of laundry. I want to meet the person who ever established what that statistic is and how they maintain it. I remember from the first time that I got it, it was something that I accepted rotely, and I assume that everybody else continues to do the same thing. You thank the manager for the laundry for giving you the information, and you move on. And it will be in modernized version, it's still the same. They're still doing laundry. There may be other things they're doing as well, though, that aren't at all mentioned. The whole disinfecting process is not at all addressed in the annual filing specifically. So all the instrumentation and all that cleaning is part of a department, but we want to make sure it's in the right department and on the right cost center schedule. And the basis of allocation, we're evaluating, comparing to what CMS is currently using. And there are a number of metrics that you'll, if you've done the annual filing, know that are Maryland alone. And we don't look to change those unless we see that there's a better measure today. Last but not least, wanted to just mention that as we progress forward, I want to reiterate that we have one purpose in being the support to the HSCRC, and that is that we are bringing an amount of experience that hopefully is helpful to them, but we're also, our biggest job is to drive this process with the work groups. So if we can get your participation and we can get your ideas and feedback on what needs to get fixed and what needs to stay the same, we will do this very well. And so I hope that leaving today, you think about where in your organizations for these kinds of topics, the best and brightest mind that can be brought to that work group process is the person you send. So thank you for your attention, and I'll turn it back to Karen.
Thanks, Bob. You couldn't help yourself. You're so excited for the survey. You stole my thunder. So as Bob mentioned, but hopefully you all know because we did send out some communication, we are sending out a survey tomorrow. Yay. I know that's what you're all thinking. So we actually, we've designed a series of surveys. We think it will be 2, but the first survey is going to be due back on February 23rd, so a little over 2 weeks. And so we really wanted to split out the surveys to give you time to focus on the physician costs. I would like to mention this is not costs. This is understanding the financial arrangements that are happening with clinicians. You're not asking for any cost information. We have tried to limit the scope of the survey to 17 questions. So hopefully you won't find it too terrible. To assist in this process, we have created a list of frequently asked questions, which will get updated as often as we get the same question. We also have scheduled a Q&A session on February 13th during your lunch hour from 12 to 11. It's completely virtual. It's also voluntary, but come, bring your questions, your things that you think, please look at the survey, but bring your questions, things that you don't know how to answer, things that you are like, well, what are you trying to get at with this question? So it's really just a time. It's not going to be us really talking at you. It's a time for us to be available and answer your questions in real time to hopefully then give you just about 2 weeks to go and bring it back and answer the questions. It's really important that as many hospitals participate as possible because the results of this survey are going to be used in our first pass of creating the new supplemental schedule on capturing physician costs. And yes, we are going to have a work group, and yes, we are going to run that by the work group, but this really is going to inform us as we begin creating it. So the more information we have now, the better. It's really an opportunity to kind of, give your input and voice to the process. And so, like I mentioned, and like this says, we are creating, the end goal of this is to create a supplemental schedule to the annual filing on physician costs. We plan to send out a schedule test in April or May of this year on, I think, prior year data, and then another test schedule in the fall. None of this data will be used for anything. It will be used to get you familiarized creating the schedule and, kind of give us feedback on it. And then with the eventual hope of incorporating it fully when we go live with the e-tool in fiscal 2025. So, sorry, this isn't on here because we didn't have a firm date, but we actually have scheduled our first work group. Very, huge thank you to MHA for allowing us to host it there. So on March 19th from 10 a.m. to noon, we will be hosting our first work group related to what we just talked about. We don't have a finalized agenda yet, but we really anticipate that the focus is going to be on physician costs, reviewing aggregated results of the survey, and hopefully providing a first pass of the supplemental schedule that we will have been creating. We are encouraging everyone to come in person if possible. We just think that being in person allows for a more real-time I can't say the word, collaborative discussion. But of course, for people that are unable to attend in person, there will be a webinar link. What we have done on our website is, so if you go to the HSCRC website homepage, you will see a little blurb and a link that will take you directly to where the project information is located. So you'll be able to sign up for the Q&A, you'll be able to sign up for the webinars. And one thing I think is really important to stress is normally when we have work groups, we kind of operate on a predefined template of these are the work group members. These are such vastly different topics that we just want the person that you think brings the most expertise and can answer these questions. So the person that comes to the first 2-3 work groups on physician costs doesn't have to be the same person that you're sending when we eventually pivot to talking about the overhead cost allocation or the cost centers. And so I just want you to keep that in the back of your mind. So we kind of talked about the stakeholder involvement. Hospitals are probably the most critical stakeholder, but of course, we will need input from MHA, payers, and other stakeholders. You're welcome to email us with questions anytime. It's me. Hi. So my email is in the frequently asked questions that are on our website. So yeah, that's what we have. Do you have any questions for us?
Oh, we do have questions. Everybody's warmed up from lunch.
So I apologize, I have not read the FAQ.
Oh,
yet.
I'm sorry.
Okay.
The FAQs will go live. They'll go live tomorrow. We're sending out, when we send out the survey, we're going to send out a blurb of what the survey is with a link, and the FAQs accompany the survey, so it will go up there.
Okay, I appreciate that. I was wondering if you could elaborate a little bit on what you mean by capturing the financial arrangements for the physician cost survey.
At the outset, what we're looking for, because each hospital or each system operates in a different environment. Some have physician organizations, some don't. Some structure them differently. And what we're looking for is to understand, in the bottom line is understand where and how far the relationships go. Are they to the hospital specifically, or do the physician relationships extend into a related organization that's who is being contracted? So it is baseline information to understand what is the nature of the relationship that puts the physician in place. The most simplified one is their employees, but there are a number of contractual relationships that go across organizations, either related or unrelated, that we're trying to understand how much of, and it's still, again, it's all about scale, how much of that is in place, and how might that change what information we need to gather. So it's all with an eye towards what will develop the best and most informative supplemental schedule. Hopefully that answered your question.
This side of the room's been quiet, even though I let you guys have lunch first. So I'm going to stand over here and put some pressure on this side of the room for some questions. What, Karen and Bob, what challenges do you anticipate experiencing with this modernization of the cost report as you're going through the project?
I think we probably have come at it from different lenses. So I'm doing a lot of, I'm involved in it, but I'm doing a lot more project management. And I think one of the biggest challenges is just the short timeline that we have is we're trying to balance giving hospitals time to fill out these surveys and have work groups, but we also are trying to balance giving them the opportunity to fill out the schedule, a couple times to get used to it. And it's just, time goes very fast. You blink and it's next December. So I think some of the timelines, but with your participation, I think we can make it. And I think Bob has very different ideas.
Just one addition I'd make, that one of the things that we have spent a lot of time talking on at the very beginning of this effort, which has been going on since the fall, is that the utility that the annual filing takes on, it affects a lot of different policy decisions and is integral to those policies. And to the extent that what we're doing is in any way shifting between cost centers, clinical cost centers, then it starts to change some of those outcomes. So what we're very cognizant of is measuring or predicting what those impacts will be as we're discussing them, so that we understand the significance of what we're doing before we get to the point where we're trying to get a final answer. So that to me is paramount, that we have good measurement of that, so that when your hospital comes through this, there isn't a turmoil over the fact that their rates have changed dramatically because of it. That is a force that we want to steer away from as opposed to accept.
I have a quick question. So with physician expenses, and you said you're sending out a survey about what types of physician arrangements, are there any thoughts of encompassing that definition? So you're also including physician extenders versus having, because right now
Yeah, I should have used the
sort of
term.
on a different schedule.
It's a clinician.
But a lot of times,
Yeah.
they're just merged together, and hospitals can't really split that out.
And I made the mistake that I correct a lot of other people on, and that is that we're using the term clinician. And the clinician definition we have is physicians, nurse practitioners, and PAs. So we are including all three in this survey.
Anybody else? All right, guys, thank you very much.
Thank you.
Hi everyone, can you hear me? I'm assuming yes. Hi everyone, my name is Lonnie Nguyen and I'm currently an intern at KPMG. And today I have the pleasure of introducing Alan Pack and Kate Cooksey for their discussion on volume efficacy. So Alan Pack has been a principal deputy director at the HSCRC for the past 6 years. He is director of the Center for Population-Based Methodologies, overseeing the development and implementation of HSCRC financial and quality methodologies. Prior to joining HSCRC, Alan had several positions in state budgeting and finance, including CFO for the Maryland Department of Health and CFO for the Maryland Health Benefit Exchange. He currently lives in Annapolis with his wife and 4 children. Joining Alan is Kate Cooksey, who is the Deputy Director of Rate Setting at the HSCRC. She has been with the Commission since 2013. As Deputy Director, she oversees all hospital rate setting functions such as rate order issuance, compliance, and rate reviews. Additionally, she co-leads core Commission activities related to the update factor and review of hospital-specific activities. Prior to her role at the HSCRC, Kate worked in claims auditing for third-party payers, and she is a graduate of the Pennsylvania State University. She spends her spare time with her husband and 2 children. Please welcome Alan and Kate to the stage.
So it's getting a little late in the afternoon, and I'm going to talk about volume efficacy. If you end up yawning or, heaven forbid, fall asleep, I'm okay with that. I just want to be very clear. And also, if you ever want to talk about volume efficacy offline, it's something I love to do because my wife hates me talking about it. So that's. Today, Kate, Riley, and I are going to talk about 3 subjects. First, the concept of volume efficacy. That is the degree to which we are effective at funding changes in volume at a 50% variable cost factor is how we measure it. Then I'm also going to talk about the out-of-state methodology we currently have, how we're going to be engaging a work group to formally promulgate that policy and bring it to the Commission for approval. And then Kate's going to talk about the deregulation policy, which similarly we have a methodology for, but we need to do a little more refinement and then bring it to the Commission for approval. So let's jump right into some of our fun cartoons. I think it's important to note a guiding principle I have, and I think a lot of us at the Commission have, which is trust but verify. And And this works both ways. From the regulator's perspective, we should trust that hospitals are responding to our interventions through sound interventions, not gaming, not upcoding case mix in order to do better in the demographic adjustment or market shift. We do trust that hospitals are doing that. But at the same time, we need to verify that. And that's why we have things like having hospitals comply with audits. An excellent example of that is in our quality policies. We have the MHAC policy, which measures potentially preventable complications. To ensure that that policy is valid, we make sure that the present on admission variables are accurate. So that's just a basic concept of the HSCRC. We trust the hospitals, but we do need to verify. Additional things we can do is we can have hospitals participate in care redesign evaluations. A lot of our commissioners, particularly now, are very interested in seeing how hospitals are actually being successful, and CMMI as well. That's why they continue to ask us to do case studies and learning collaboratives, because they do think of us as the model for the country. You know, it's a very august title, but at the same time, it's a heavy burden as well. And I think if we continue to have these types of engagements that MHA does a wonderful job getting people to participate in, we can then scale them not just across the state, but potentially the national landscape as well. From the other side, you know, the regulated entities should also trust that we are putting together policies that are achieving their intended outcomes, but you should also have us verify that they're working. And that's why we do things like also have data reporting and audits or scorecards, which I'm going to talk about in a second on our volume policies. But also we have additional measure sets that we look at, like ensuring that there's necessary process and structural measures, or that there's correlations between intended outcomes. So Allison and Jeff earlier talked about ED length of stay. One would anticipate if you improve ED length of stay, you're going to have better patient satisfaction. So we would measure both of those to ensure that both are being met. If they weren't, we would be concerned that potentially there's some sort of gaming involved. On volume, I would say it's a little bit of a burden because the verification is a little more difficult sometimes. It's multi-pronged and difficult to ascertain. And before I get to that, I also want to say, generally developing policies is tough work. I think the architects of this model, the Donna Kinzers, the Shule Gareviches of the world deserve a lot of credit for developing really sophisticated policies like the demographic adjustment and the market shift policies. And while that is very difficult, I would submit to you, I sometimes think it's even more difficult to prove that they're working and then to modify those methodologies subsequent to that. And so I do think we've had some successes over the last 5 or so years, which is number one, to actually come up with a scorecard to determine how well our volume policies are doing, and then number two, to tweak them. You might recall a few years ago, we looked at the market shift policy and we consolidated service lines and we consolidated geographies because we were concerned there was some random variation that was being scored. I think we've actually improved those policies as a result. The demographic adjustment is another good example. There was a forecasting error that occurred in the last census, which I'm still somewhat angry about with the Department of Planning. But that required in this last update factor for us to do a major substantive change to account for that census catch-up, which is why there was an extra $200 million built into rates. Those are the types of things we have to be nimble enough to account for, and then report back to you on how our overall volume policies and all of our policies are performing. Which brings me to one of my favorite slides. It's the thing that got us out of doing volume variable about 6 years ago. And this is our current scorecard of how we are funding in-state volume change through the demographic adjusted and market shifts. I previously used to show this as demographic and market shift by themselves. I just combined them here for simplicity. But I do also want to mention that in the future, I think the scorecard needs to grow further. Right now, I'm just focusing on in-state volume, which, as I'll mention in a second on the next slide, is only 70% of our volume. There are other things at play here that we need to develop policies for and then scorecard them as well. So that is your out-of-state volume. That is deregulation adjustments. That is potentially avoidable utilization. I think that's a really important one because we purposely don't fund potentially avoidable utilization, but I don't think that should preclude us from scoring it so that hospitals can see potentially hospitals are overfunded for regular in-state volume, but maybe some of the shared savings that we're taking from PAL is actually eclipsing how much you're overfunded through the demographic and market shift for non-PAL cases. So just to acclimate you to the slide, what this shows you is if a hospital was on $0, that would mean that they were exactly funded at a 50% variable cost factor for all the changes in volume. Any hospitals on the far right have been overfunded for volume relative to that standard. We are not trying to true up to that standard, but we want to report back on that standard, particularly because that might mean that we have to change some of our population-based methodologies. So as you can see on the far right, Johns Hopkins has been overfunded relative to that 50% variable, volume variable standard by the tune of 60 million. And on the far left, you have some subacute facilities that aren't doing as well. And you also have Western Maryland, which has incurred a fair amount of population declines, but has not gotten the same amount of use rate out. Okay, so that's all I wanted to mention there. This is sort of going back to that slide. I do want to, again, mention it doesn't account for all of our volume. It's only 70% of our volume. And that's the in-state cases that are handled through the market shift and the demographic adjustment. What is excluded from this is out of state, which I'm going to go over in a second. We have a methodology for that, never been a formally promulgated policy. It's about 10% of revenue. Potentially avoided utilization, that is about 11% of revenue. That's your readmissions and your PQIs. We purposely don't fund population growth for that, any type of volume growth for that, and inflation. And I do think that's a future question for the commission. Can we do that in perpetuity as a haircut? I think it made a lot of sense early on from my own personal perspective because we put $200 million into infrastructure and we were sort of clawing back that investment. But over time, I think it's important we remember the P in potentially avoided utilization very much means that it's potentially avoidable. Some readmissions need to occur. We don't want to compromise access to care by having a potentially avoided utilization program that in perpetuity provides a haircut to the system. Next is radiation and infusion therapy and drugs. That's the drugs that are handled through our CDSA policy, which is a standalone volume variable policy. That won't be in the scorecard in the future, I should mention, because it automatically handles itself since it is a volume variable policy. And then lastly is the defined quaternary cases, which is an additional volume policy that right now is exclusive to the academics for highly complicated cases, where they do get a prospective amount for historical annual growth for things that we deem to be complicated and innovative. So in terms of the methodologies, I'll first talk about the out-of-state background. When we started global budgets in 2014, not all hospitals actually had their volumes under global budgets, their out-of-state volumes. That quickly changed about 2 years after the fact as everyone brought it in-house. And I think it's also important to note that in every global budget agreement with hospitals, we do have a clause that says we can do adjustments if there's material changes. We have done material changes on an ad hoc basis when hospitals have come to us, but I want to create a policy that we do more formulaically with the advice of work groups on how we implement that, and then eventually have the commissioners approve it, because we're always better if our policies can actually stand behind a commission vote versus staff doing ad hoc assessments. In the out-of-state methodology, what we currently use is reported experience data, so patient days, labs. We do not use ECMADs. And the reason for that is that these are longitudinal assessments that have base years under different groupers, different case mix methodologies, and different diagnosis and procedure code versions. So it's virtually impossible to do an ECMAD evaluation, which is the ideal. You could do conversion factors, but I've seen those before and they don't exactly work that precisely. So I do think we're going to stick with reported experience data. There is an unintended consequence to using that data, though. We moved away from that. The entire industry in Maryland and nationally moved away from using per diem type of evaluations because hospitals can gain them. You can actually have a result where we are providing additional funding if a hospital is increasing the number of labs for a patient or holding them for an extra day. I trust the hospitals don't do that, but we do need to have verification, yet again, that that's not occurring through this methodology. And that's why we have, as I'll talk about in the next slide, materiality thresholds. The other thing that can happen is if you are doing adjustments related to an increase in patient days for out-of-state volume, and you're doing it year after year without materiality thresholds, you're going to start creating adjustments that undoes one of the hallmarks of the industry, which is we have predictable global budget revenue. So for example, a hospital grows by 1% next year, and the subsequent year they decline by 2%. Do we really want to be doing these adjustments each year, or do we want to just provide them a predictable revenue base, which is what a lot of the other states in the country are pointing to as a reason they want to actually move to this model. So I think by having the materiality thresholds, we sort of undo both of those unintended consequences. So in terms of the out-of-state volume methodology specifics, the formula is fairly straightforward. This is actually one of my easier methodologies. Essentially, it's just the current rate for every hospital times the performance year volume minus the hospital-specific base year volume. Obviously, you do current rate because you want to get to current dollars, and you are going to go relative to a much further base year period for most hospitals, 2014. And finally, you multiply that by 50% to get back to that gold standard of a 50% variable cost factor to realize the marginal cost with providing an additional unit of volume. Again, while ECMADs are preferable, we are using financial reported data, as I mentioned, for a variety of reasons, and we think it's okay as long as it's coupled with materiality thresholds, and they are as follows. This is not final. It's what we've done thus far, but this is what we are currently using, and I hope to have that engagement with the work group about what is the reasonable materiality thresholds. They are that a hospital needs to demonstrate that their growth is greater than 10% in out-of-state volume, and they also need to constitute more than 1% of a global, the hospital's global budget revenue. And then once both of those conditions are met, we will true the hospital back up so that materiality threshold is no longer achieved. So for example, if a hospital grew by 2%, or rather its out-of-state volume grew by over 10%, it represented 2% of their overall global budget, we would actually provide them a 1% increase so that they would fall beneath that materiality threshold. In terms of baselines, I think it's important to note that the baselines are different for all hospitals. Most baseline performance periods would be 2014, because that's when we started global budgets. There are hospitals subsequent to 2014 that went through a full rate application or actually already had an out-of-state adjustment. I think we're up to maybe 4 or 5. At that point, we would redo the base period because we don't want to pay for it twice. And then I think it's also important to note that we do have some exclusions. We exclude drugs and supplies because the volume statistic is cost, and it doesn't really lend itself to this type of analysis. Secondly, a lot of the drug costs we're already covering through the CDSA methodology, so again, we don't want to duplicate the payment. I will note everyone's favorite policy is the full rate application policy and integrated efficiency policy. If we're getting anything wrong in the volume policies, that's what I think is the fail-safe, to essentially allow a hospital to say, I didn't get paid for all the volume that I incurred. You know, Garrett Regional Medical Center is a wonderful example who had use rate growth. It wasn't getting picked up in demographic and market shift. And because of that, they fared better in the full rate application policy, and that cleaned up the degree to which the volume policies didn't get it right. I don't anticipate that these policies will always get it right because we're not just setting prices and then letting the invisible hand of the market work. We are actually trying to interpret it all the time, which is next to impossible. And then lastly, I do want to mention that for now, we also exclude material volume declines. So those hospitals that are growing more than 10% and it represents more than 1% of their GVR, you can theoretically think that it can happen on the reverse side. We have not implemented any negative adjustments. There's only 1 or 2 hospitals that actually meet that standard, but I would like to have that discussion with the work group about whether or not we should implement those types of adjustments as well. As you can imagine, they probably won't be very excited about that conversation. Which brings me to my last slide before I hand it off to Kate. Our policy development for this is we are thinking we're going to have a work group in March. It will go through June, and then ideally we'll have a recommendation in July on an out-of-state volume policy coupled with a deregulation policy as well. We'll talk about the materiality thresholds and other decision points within the methodology. And then ultimately, we're going to update that scorecard I went over to include out-of-state, to include deregulation, and also to include potentially avoidable utilization, because I don't think we can comprehensively say we're doing a great job on funding volume until we account for all of those, and that's very important. We hope to get that out of this work group. I will say, I don't know how many of you know the Greek myth of Sisyphus, but I do feel like Sisyphus sometimes. I roll the ball up the hill and it always comes back down. COVID was very helpful in that respect. And I'm sure all of you can say the same. There will be things we still need to work on. One of them being repatriation. I think that deregulation will handle it to some degree, but I don't know if it will handle all of it, particularly since deregulation right now is mainly focused on Medicare and extrapolates to all payer. And I should explain repatriation. That essentially is when a hospital is successful at bringing a Marylander back from out of state. They're potentially getting the services in DC or Delaware, and now we've brought them back into Maryland. That's a great thing. It lowers the cost per case. It lowers total cost of care. It is a wonderful thing and an advantage border hospitals have in our model. That's something we're going to need to work through as well. I hope to have a portion of that covered in this policy work group, but I don't know if we'll get there completely. So like Sisyphus, we'll keep rolling up the hill. All right, here we go.
Thank you, Alan, and I'm sure everyone is still awake because it still feels like it's 52 degrees in this room. I'm going to be pivoting and discussing deregulation for the remainder of this presentation. So what is deregulation? Deregulation is the movement of a hospital service from a regulated setting to an unregulated setting. And HSCRC staff refer to our state regulations outlined in COMAR to determine what is regulated versus unregulated. And so service movements can be initiated by payers. An example of this is if CareFirst decides that they only want to treat certain patients for certain types of procedures in an ambulatory surgery center. Another example of this is if a hospital makes the decision to deregulate a service. So most recently, we've seen a lot of oncology deregs occur. And in other instances, a service may just simply get discontinued at the hospital. An example of this we've seen is sleep studies. And then finally, cross-state line movement, such as inpatient surgery from Maryland to DC. These are all examples of what may need to be adjusted for within a hospital's global budget. So as Alan mentioned earlier, each hospital has a GBR agreement between the HSCRC and the hospital, and there's language within that agreement that outlines the requirement to notify staff of any shift of service or new acquisition. So regardless of who initiated the shift to unregulated, HSCRC staff need to be notified to ensure that an appropriate adjustment is made to the hospital's global budget. With that said, we do not always get timely notification or notification at all. So the burden of proof falls on HSCRC staff to identify potential deregulation that we have not already captured in your global budgets. So how do we do that? We're working towards a formulaic and transparent process that outlines our policy to ensure that we're capturing and adjusting for all deregs that happen over a specific time period. The goal would be to capture deregs that we were not notified about, but also use this tool as a verification process for deregulations that we have already captured within a hospital's global budget. So the most recent review process that we utilized, and again, this is the focus of my presentation is mostly on the tool or policy that we're going to use outside of hospital notification. So this is, again, the emphasis is to ensure that we're capturing all deregulation that happens and verifying the ones we've already accounted for. So the most recent review process utilized two sources available to HSCRC staff. The first one is the unrecognized market shift data. The positive of using this data is that it's all payer in nature and derived from hospital submitted case mix data. The roadblock to using this data on its own is that it does not contain non-hospital activity, so it's difficult to determine if the volume loss was due to deregulation or dissipated volumes through the GBR framework. And what I mean by that last point is that we do expect there to be some volume loss when hospitals are correctly responding to the incentives of the model by keeping the population of their patients healthy, and then those patients no longer come to the ED or require acute care utilization for diabetes or COPD or asthma. And then in addition to the unrecognized market shift data, staff also reviewed Medicare claims data from the chronic conditions warehouse. And this is a Medicare-only data set. It's not used in any of our hospital rate adjustments. However, we are able to review and observe offsetting increases in another place of service. So we can observe that there was a decline in hospital Medicare hospital claims, but we also can see that there was a corresponding increase in an outpatient setting. And in an effort to make this data set usable in our methodologies, staff assigned ECMADs to the claims data. And as a reminder, I know Claudine mentioned what an ECMAD is, but an ECMAD is an equivalent case mix adjusted discharge, which essentially is a weighting system that we use in our case mix data for our methodologies. And so utilizing the sources I just highlighted, staff then went through the following steps outlined in this slide. And so this process was shared at Technical Issues last summer. And based on this review, several hospitals were identified to have potential deregulation and subsequently received letters from us that then opened the door for further conversations, requesting more detail or verification. And so this slide is a bit wordy, and it's also maybe difficult to conceptualize without actually looking at an Excel file that you can see how the formulas flow. So bear with me. So this first steps aims to quantify declines in the unrecognized market shift data and shifts in place of service away from the hospital using the Medicare CCW data. And this step requires extrapolation to an all-payer value. The next step involves flagging a service line for further review if there is both a material unrecognized market shift decline or place of service shift using the Medicare data. I believe we used a 20% threshold as what we considered to be material in our review. We then quantified the amount of a dereg measured in ECMADs as the lesser of the unrecognized market shift decline or place of service shift, and then find that potential dereg was then validated by reviewing the underlying data for that service line and converted to dollars using hospital-specific charges per ECMAD for that service line. I think that step is important because it denotes the dollar value relative to the hospital's charge structure. And then finally, assuming no other data flags or other issues are identified, the HSCRC staff then shares this data with the hospital for input, verification, validation, and further communication. Okay. So utilizing the methodology outlined on the previous slide, it may be unsurprising that most of the shifts occurred in major and minor surgery. And why is this? It's because most deregulation occurs in outpatient services, and surgical service lines are susceptible to site of service change. Major and minor surgeries are amorphous service lines. So to give you an example of that, major surgery has 94 unique EAPGs associated with it when the average is 34, but some service lines only have one EAPG assigned to them. In addition, there's a wide range of procedures that exist within these service lines. And so one of the biggest criticisms that we heard from hospitals is that they were not able to ascertain from their data what specific surgeries were shifting. So given the feedback that we received from hospitals to date, plus the review that must occur to ensure that adjustments were not already accounted for via market shift, staff have considered creating a new methodological tool. Is that on the slide? Is that a G slide? Oh, okay. Couldn't remember what slide it was. It's an EAPG DRG level analysis aimed to quantify the same geography as currently identified in our market shift policy for a hospital, but will be aggregated by EAPGs or DRGs in lieu of service lines. And this, Claudine also mentioned what EAPGs and DRGs are, but as a reminder, they're inpatient and outpatient groupers associated with 3M. But we will be ensuring that our analysis is normalized to regular market shift values. So there's still a lot of work to be done to fine-tune, finesse this methodology. But if you're captivated and want to learn more, we intend to convene the volume subgroup, as Alan had already pointed out, sometime in March, and then work over the next several months to get stakeholder input and bring these policies outlined on this slide to the commission sometime in the summer. So with that, are there any questions?
Questions? While you're thinking of questions, one special shout out for Kate Cooksey. She is amazing in wrangling speakers from the HSCRC. This event would not happen without her. So a round of applause and a special thank you for Kate in particular. What would really make her happy and feel appreciated would be a question.
A question I have is, you know, we always talk about getting the right patient to the right place at the right time for the right care. And as we consider moving, as hospitals consider moving care delivered in the hospital to an unregulated place, the opportunity then is to provide that care in the hospital for the folks who need that care. And so one of the questions I have is philosophically, the moving towards regulated to unregulated with the offset of actually being able to provide the right care in the hospital to the patients that require it. There's a balance there that has to be struck between the analysis that needs performed is maybe it's not just a complete offset, but what I struggle with is if we just consider the movement of volume to the unregulated space and that offset of potential patients coming in for the acute care that's needed in the hospital, then the analysis should include that type of balance that needs to be struck.
So essentially, you're identifying the idea of backfilling, right? So you got out less acute things, and then you maybe potentially replaced it with more acute services. Certainly, if that happened concurrently, then all our methodologies wouldn't actually ever penalize you for removing services, because if it was immediately backfilled, then there wouldn't actually be an identification of a decline that we could take out through the deregulation policy or through an out-of-state adjustment or anything like that. It is an excellent point, though, that perhaps we got out a lot of less acute services, sleep clinics, labs years ago, and now we're backfilling. And that's why, number one, we do have the efficiency policy to the point that you are actually backfilling, becoming more efficient. We can actually provide you an enhanced rate structure. But also, I think it sort of speaks to the scorecard. If I were able to see that, yes, I'm going to get it wrong on your particular unit of volume that you've now brought back 3-4 years later, but if I can show in aggregate that your actual overall volume funding is appropriate, if not robustly appropriate, I don't think that should deter hospitals from bringing back that volume. The other thing I would mention, and I think it's one of our biggest issues with the quality team, we are trying to get people into the right place. And oftentimes, if you know, hips and knees being done in an outpatient setting or even an ASC, potentially is better because it's a cheaper price point. What we don't have any lens into right now is whether or not those quality outcomes are great. And so I think, you know, I know the quality team is working to sort of extend themselves beyond inpatient, which is where we typically reside. But it might actually have to be further than that. And then we run into the issue of regulatory barriers as well, because the HSCRC's footprint, I mean, our accountability extends beyond hospital, but our regulatory framework stops at the hospital wall. And I think that's something we all need to think about in the future if we're going to continue to push things, not just from inpatient, outpatient, but outpatient to ASC. How do we ensure that we're getting the best quality outcomes?
Other questions? All right, guys, thank you.
Yep.
All right. So as we go through our day, we'd love to hear from the HSCRC, but I also want to have in our content some advice about what to do to improve the hospital operations as it relates to some of the HSCRC policies. And so our next speaker, Jonathan Sachs, is a healthcare leader who is focused on improving patient experience, both in the hospital and outpatient settings, using design thinking and innovative solution. He currently serves as the Chief Executive Officer of WUDA, which is an acronym, what do you want to talk about? A patient experience technology company that increases referral volume through video push notifications to patients. But Jonathan was also served as the Vice President and Chief Experience Officer at the Robert Wood Johnson University Hospital, as well as the VP of Experience Transformation at Adventist Healthcare here in Maryland. When he was at Adventist, he was part of his portfolio was looking at patient experience, foundation, digital health, and innovation. So please welcome Jonathan.
Thanks. Good afternoon, everybody. It's great to be here with you today. I wanted to really thank you for your time. Thanks to HFMA for having me and the HSCRC. Thanks to James Case for thinking of me today. And thanks to Joe Drayetta in the front row, because without him, I would not have gotten through accounting and business school. So thank you for that. Learning objectives today, really talking through what is HCAHPS, how is it measured, how is it used as part of the QBR methodology, and going through things that you can do right now to positively impact these scores. And as we heard a little bit earlier in the ED discussion, Maryland has a lot of work to do to improve on HCAHPS scores, and I'll talk a little about that today. My passion for patient experience comes from a number of different places, and I'll share it with you as I go through the presentation today. But I want to share with you actually one of my earliest memories of getting care myself. For one of the first times that I saw the doctor. So I remember being like 10, 11 years old, and my friends had, their earlier birthdays, and they'd gone to their checkup, and the doctor checked them out on the growth chart and said, you're going to be 6'3", and the next person, you're going to be 6'4", and you're going to be 6'2". And I was like, well, I want to be tall also. So I begged my parents, can you take me to the doctor? And they were like, you want to go to the doctor? And I was like, yeah. They're like, all right. And I had all my shots and my checkup and everything, and went through, and they checked my reflexes and gave me all my vaccines, all that kind of stuff. And at the end, the doctor said, hey, you're good to go. And I said, well, no, I'm not. I have business to take care of. I'm 11 years old. I need to know how tall I'm going to be. He said, Jonathan, I've got some good news and some bad news. He said, the good news is you're going to be just like me. The bad news is that means you're going to be short, fat, and Jewish. So here I am, doing the best I can at proud 5'8", and moving forward there. So even then, it was like, all right, I think this could get a little bit better. I think we could improve in maybe some bedside manner or other things when it comes to patient experience. And then when I got into the hospital, I realized that this attitude was kind of pervasive. That if you ask most clinicians, hey, what are you doing about patient experience? The answer is, I don't really have time for patient experience. I don't know if in your institutions, if you've heard this, it's this idea that, I'm saving your life. You want me to give you candy or a sandwich also? Isn't that enough for you to do that? And I think it really represents kind of a fundamental shift that we need to make in hospitals in our point of view around patient experience. And the best way I've seen this articulated is through a company called Forrester's, and they do ratings of all different kinds of industries around experience. So they share the best industries are things that you would think about, hospitality, experiences, and some of the worst are like insurance is what they mentioned, hospitals. It's this big range. And what they say the difference between high-performing industries and low-performing industries is a perspective. And that perspective is, are you looking at your work from the inside out or from the outside in? And I'll give you an example of what I mean around that. If you think about just generally work at a hospital. So work at a hospital is really difficult. And I remember seeing the story of a patient who was in Portugal, really humbling story about a patient, and the patient had a diving accident. And the way that he describes it is, I'm in the water and I hit my head and I'm face down in the water and I think to myself, this is it. I can't move my arms, super scared. And then a wave comes and flips him on his back and takes him to shore, and he blacks out. Next thing he knows, he wakes up in the intensive care unit in Portugal. And when he wakes up, what's the first thing that he does? He screams. He can't move his arms and legs. He's scared, but nobody comes. Nobody comes to help him. Why does nobody come to help him? Because it's Portugal, and this is the diving unit of the hospital. So yes, it might be the worst day of your life that you're all of a sudden paralyzed, but the clinicians see this every day. They kind of get numb to it, and they're like, well, we have our work to do on you. We have our perspective. We come to work. We see you. We're trying to address things clinically. We're trying to do all of our bundles. We're trying to make things work, trying to document an EMR. You're there. We're gonna treat you, and that's sort of the transaction. But to the patient, it's like, yesterday I didn't want to be in the hospital. like this is the worst day of my life. And seeing the work really from that side changes the approaches that you can make in order to improve your HCAP scores, and I'll go over that. In addition to my small patient experience, unfortunately, everybody in my immediate family has had major surgery. My sister was born with hydrocephalus. She has a shunt installed, which basically drains excess cerebral spinal fluid from her head into her abdomen. Dr. Ben Carson actually operated on my sister at Hopkins. Both of my parents have had neurosurgery, and I can tell you that when a patient comes to the hospital, there are three main emotions that they feel. They're scared, they're stressed, and they're confused, no matter what. And I shared this when I was at Adventist Healthcare, and it was really amazing to me when I would round in the hospitals after that clinicians would come up to me, nurses and doctors would come up to me and said, I heard you say that thing about being scared, stressed, and confused, and I didn't really get it until my son broke his arm and was in the ED. And I work here, and I was scared, stressed, and confused. I wasn't sure what was going on. I wasn't sure how to navigate things. I wasn't sure how long the wait was going to be. So when that's the orientation, when you start from that point of view, how do you make progress there? And that's part of what I want to get into today, is how do you establish trust with a patient in a way that recognizes their experience in addition to what we have to do for them clinically. So here's what I mean by that. Raise your hand if you've ever had to go to a mechanic for your car, please. Okay, just about everybody, that's what I figured. How many of you have a good working understanding of the way your car actually works? A few of you, I'm impressed. I have no idea. I have zero idea. And so when I go, the question becomes, and for the rest of you who didn't raise your hand, when the mechanic comes out and, usually they've got a rag and they're wiping the grease off their hands and they say, this is what's wrong with your car, how do you trust them? How do you know to believe them? And the answer is usually, this is what I hear, they spend time and explain it to you. They look at you and they say, I could do this $3,000 fix, but really you only need the $300 fix. And what happens to you at that point in time? You're like, this is great. Like, I can trust this guy. He's not ripping me off. I feel good about it. I have no idea what he's doing. I have no idea what he's talking about. But I got this good feeling that it's going to be okay, that he's not trying to rip me off, that he's actually trying to fix my car, that I'm going to be safe. And to most patients, that's the experience in a hospital. We don't think about it that way. But the average patient, like, what do they know about their body? I mean, think about it, like 10th grade biology. I mean, that's kind of the furthest that most people got. I mean, the clinical terms that we use in a hospital are confusing and jargon and difficult for patients to understand. And that's really what kind of comes out that I've seen in the data of the HCAP survey is this fundamental shift that we have not quite made yet from inside out thinking, there's the job that we have to do to you, to outside in it thinking, what do you need in order to feel cared for, in addition for us working on your chronic condition right now or your condition right now. And that's really where the HCAP survey comes in. The HCAP survey attempts to measure in a standardized way how patients perceive their care at hospitals across the United States. And the idea that CMS looks at when it comes to the HCAP survey is that patients are essentially going to shop for their hospital. It gives them the ability to do that. So what you can do is if you're looking to get care at a hospital or you want to see how your hospitals rate in your area, you can go up to CMS Hospital Compare. These are some of the results for hospitals near us. In full disclosure, I just typed in my zip code, 21208, so that's how those two hospitals are there. And you can go through and see a comparison. Now, do patients really shop around for their hospital? Sometimes patients shop around for a hospital or patients shop around for a doc, especially in an area where they have choice. Like if they want to make a decision about OB care, for example, where they're going to have their baby, where they're going to get knee surgery. They shop around for that, but it's usually at the guidance of their doctor. I'm not sure how many people are using Hospital Compare like kayak.com. I'm not sure how many people are doing that, but it's there for that purpose. In addition, HCAPS is a signal to others about the quality of your facility. HCAPS results are used in several different methodologies. Many of you are very familiar with this. It's used in the Leapfrog Hospital Safety Grade. It's used in US News and World Report. And of course, it's used by the HSCRC to determine your quality-based reimbursement penalty or bonus. And the HSCRC, I have to say, has been really quite progressive and aggressive compared to the rest of the country in factoring HCAP scores into quality-based reimbursement or value-based purchasing. As we heard earlier, it's about double the weight of any of the national program in terms of how HCAPS is counted. In addition, the HSCRC QBR methodology uses both top box and linear mean, which I'll just get into in a minute. And part of the reason why that's happening, why the HSCRC is so aggressive, is because of Maryland's overall performance in the country in terms of HCAP scores and patient experience. So CMS publishes data on 53 jurisdictions. So it includes the 50 states, the United States, DC, Puerto Rico, and the Virgin Islands. Maryland ranks 48th out of those 53. A few years ago, it used to be a trick question. I used to ask out of 50 states, how did Maryland perform? Maryland was actually 51st on the list, so we've made some progress. If I don't know about you, but considering I get care in the state, my family gets care in the state, I'd like us to do a little bit better, at least, than 48th. So the question that I would first ask when I see this data is who's at the top of the list and why? And what do we have in common with them, and then who's at the bottom of the list and why? So I wanted to share that with you, and this is 2022 data, is the latest updated data. So at the top of the list, you have South Dakota, Nebraska, Iowa, Kansas, Utah. At the bottom, New Jersey, New York, DC, Puerto Rico, Virgin Islands. And then we check in at 48, just ahead of this number. So what's the difference? So Brian Sims from the MHA and I were talking about this a little bit at lunch. Is there a mid-Atlantic bias? Is there something about the bay, I don't know, the water here, the Atlantic, that's making it, so that we're more challenged to improve HCAP scores? And there's a credible argument here, the fact that the population tends to be well-educated, high standards, elsewhere, other sorts of things that we have, demographically very diverse, that might lend to this. But actually, in analyzing the data, what I found super interesting is that it's actually not correlated with any of that from what I've seen. It's actually correlated towards response rates. So the places that tend to do better tend to have response rates in the low 30%, so up to 34, 35%. And the states that tend to do worse have more of like an 18% response rate. So what I'm really kind of interested in is there's a revision happening to the way HCAPS is collected. As you know, today, HCAPS can only be collected via snail mail or via telephone, that there's no email option for this survey, there's no text option for this survey. So the good news is CMS did discover the internet in 2025 and is allowing for email surveys starting January 1st, 2025. And from a response rate perspective, I'm really curious as to how that's going to translate to our ranking as a state, because seemingly you would expect that the response rates would be higher in an electronic survey versus a snail mail survey. So we'll see what happens there. In addition, these rankings are based on top box. The QBR has added a linear mean score as a part of that, and that also could be helpful for the scores. But fundamentally, I don't know about you guys, but I find these scores to be unacceptable. I personally think Maryland is exceptional. I might be because I'm from here and I'm just passionate about our state. But I think that, our rate setting system is exceptional. The way that we do our work is exceptional. We have one of the best hospitals in the entire world here. Why is this not better? And I want to give you some strategies today to improve it quickly and to really dig in and understand it so that we can all make progress together as a state and be proud of where we end up in just a few years. So what exactly does the HCAP survey measure? And this is really important. So there are 22 questions on the survey, and then there's 7 demographic questions after that. And then hospitals have the ability to add custom questions, which the HSCRC, I understand, is looking at having common questions among all hospitals in Maryland being there. And these are the domains that are reviewed: overall rating, communication with nurses, communication with doctors, responsiveness of hospital staff, the hospital environment, et cetera. I will tell you, I have read and reviewed and analyzed over 1 million patient comments during my time as a CXO. And I can tell you that really it boils down to 3 things when it comes to this survey that patients really care about. The first thing is, did my nurse spend time with me? Do they care about me? Am I seeing evidence that they are actually spending time with me and making me better? Second is the same thing for the docs. Am I seeing evidence that the docs are spending time with me, that they care about me, that they're treating me well? and explaining things to me. And then the third is, can I see evidence that they're actually working together? And the third one really surprised me, but it makes sense. Patients are sitting there, they're listening to what's going on outside of the room, and they're making determinations about whether the team is actually communicating on their care. And so that one came out as well. So currently, the way that most of these domains are reviewed is they're all treated equally right now in the QBR methodology. And the question really is, are they all equal? Do they all matter equally? Are they all, from an outside-in perspective, things that the patient cares about equally? And the answer, and you demonstrate this statistically, the highest correlated with overall rating is nurse communication followed by doctor communication. The answer is no, not really. There are some of these areas that patients care about more than others. And then there are some things that the HCAP survey doesn't even touch or talk about that are also very important to patients. So how do you work around that as well? Now, the questions of the survey are not super straightforward. They can be really tricky as well. So, knowing the problem that you're solving on HCAPS is a huge part of how you actually make progress here. And I'll give you an example of what I mean. When I was at Robert Wood Johnson University Hospital, we were seeing our cleanliness scores decline. So there's 2 questions in the hospital environment domain, and one of them involves cleanliness. And the question is, why were those going down? So we tried everything. We were going into the rooms and leaving little tent cards that said, "I cleaned your room," in big letters, big bold letters. "I was here, I cleaned your room." We were using 2 different color rags so that we had a clean rag and a dirty rag, and patients could see that. We were spending extra time in the bathroom to make sure that was clean, and nothing was moving the scores. So we went in and we looked at the comment data, which is very rich, and there's a lot there. I'd encourage you, at your systems, regardless of what survey vendor you're using, to go into the comments. And we used a program to aggregate the comments in a certain place, and all of cleanliness was not talking about cleanliness. It was talking about the sheets, the bed linens not being changed, the gown of the patient not being changed. So here we were driving our poor EVS staff totally bonkers. They had a big whiteboard. They met every morning in front of it and analyzed their data at every single unit every single day. The poor EVS leader, he was just about tearing his hair out because he was doing everything that he could think of, and the scores weren't moving. We went down and said, this is really, a linen problem. And they started to check in with patients on a daily basis to say, would you like your linens changed? Would you like your gown changed? And guess what? Scores went up to the 95th percentile after that. So it's tricky. The survey asks things that you might look at it and say, oh, I think this means this. But when a patient looks at it, it really means kind of this other thing. So getting into the comments of the questions is key to improving it and work that you can do to make sure you know what problem you're solving. Another thing that's really interesting when it comes to the explanation of the survey, so of course you have the domains, then you have questions under each domain. One of the things that the QBR, the rate year 2026 QBR guidance talked about was diversity, equity, and inclusion in the HCAP surveys, and how there's large disparities between different race groups, especially in the HCAP survey results and in HCAP survey participation. So analyzing data at that level in order to understand what problem you're solving is critical. So I'll give you an example. I was working with an ED, and the ED was in an area with a very large Latino population. And their scores in the ED, which is a little different than HCAPS, but their scores in the ED had very low nurse and doctor communication scores. And the area where they were suffering was with the, did doctors explain things in a way you could understand? So we're sitting there analyzing the data. The medical director of the ED and the director of the ED, the nursing director of the ED, say, oh, well, we have a large Latino population, and so they probably don't understand what we're saying. But then we were able to dig into the data and actually show that the Latino population had the highest scores in that question, and that the native English-speaking population, we were able to use other demographics to do that, had the lowest scores. And what we learned was that clinicians were spending double the time with patients who had English as a second language to make sure that they were communicating. So what I would say too is when you're coming to see how your system is performing in HCAP surveys or how a system could improve their HCAP surveys, what I would share is make sure that you get into the data at a deep enough level that you really understand the problem that you're solving, because it's not necessarily straightforward, because it's completely subjective. It's different than some of the other measures that hospitals are evaluated for. This is perceptions and perspectives of patients and family members, frankly, in their care. Another sort of fun part of the HCAP survey, and I'm using fun in these fun quotes over here, is HCAPS uses top box primarily to measure performance. So that basically means that you either get an A or you get an F. There's no Bs, there's nothing in the middle. Either a patient sees something demonstrated always or it doesn't count whatsoever. The QBR methodology is experimenting with, I believe, 4 domains using a linear mean score. If you look at that data, that's actually closer in terms of Maryland's performance to the nation. Still not great, but that as well, I think, would be an improvement to actually count some of these scores like usually that indicates that for some patients who in their mind will never give a top score unless they have like a perfect experience, regardless of where they are, whether they're ordering a pizza or going to a hospital system, it accounts for that, which I think is helpful. So looking at the HCAP survey in general, and I've spent a lot of time with it, as I'm sure you can imagine, I always like to ask this question: does HCAPS accurately measure patient experience? Is this a good tool to really understand patients' perceptions of care in the hospital? And this is an important question because there's a lot of evidence, clinical evidence, that demonstrates that patients who say that they have better patient experience actually have better clinical outcomes. And I can tell you just personally, when both of my parents were admitted for surgery, both of them were readmitted. Even though they had basically the same surgery about 3 years apart, both of them were readmitted. And I think it was because of the lack of explanation, the lack of the experience they had to feel confident in their care when they got home. So there's a lot at stake and a lot of sort of, I would say, unused data and insights in the HCAP survey. But it's limited in the things that it can really measure and use. So I want to share with you a little bit around what I mean by this. So the HCAP survey really measures only one element of a patient's care experience. So this is a basic patient journey map, so what patients experience when they get care and the different stages of what they experience when they get care. So just to take you through it really quickly, a patient will feel all of a sudden like something's going on. They'll identify that they have some need for care. They're aware of a hospital system. They're aware of a place to go. That's stage 1. In stage 2, then they go ahead and actually get scheduled for care. In stage 3, they receive care. And in stage 4, they figure out what to do after they've received that care. What the HCAP survey basically measures exclusively is the 3rd stage, what happens at the bedside. But if you look at the data, so much more than that actually impacts a patient's perception of their care and their overall rating of care, including the ease of which it is to get in, the way that you park your car, how you access your specific doctor's office, whether or not there's digital tools for you to use when you're discharged, whether there's education for you. All of those things factor into a patient experience. It's always interesting to me listening to patients, hearing them say, I loved my nurse and I loved my doc, but I had a terrible patient experience. How does that happen? And you wouldn't believe, I mean, it happens quite often. A lot of patients feel that way and see it. And it's really because we're mainly looking at a piece of the target, not the entire thing when it comes to patient experience. As I shared, CMS is making progress in the way that they collect the HCAP survey. Starting January 2025, they are allowing for email surveys, which is wonderful. And they're, I wouldn't say allowing a patient proxy, so this is like a family member or a caregiver who would fill out their HCAP survey. I'd say they're sort of recognizing that that happens right now in many instances. And so they're sharing, yes, we're going to accept that that's happening, and we can count them as part of the results that ultimately get published on Hospital Compare. The future, to me, of patient experience measurement actually lives outside of a standard survey like HCAPS. I don't know when we would get there, but I think this is actually, in my point of view, one of the best places where artificial intelligence can be applied. And in my time as a CXO, I've spent time using artificial intelligence to do this. So if you think about any survey, and all the CAP surveys have this in common, all surveys are really designed by a person to ask questions that they want to know. Again, inside out versus outside in. It's an inside out point of view. CMS has said, I want to know your perception of the nurse communication. I want to know your perception of the doctor's communication. I don't quite so much care about your perceptions of, your parking experience or whatever. I mean, that's the way that the survey is written. What AI allows you to do is to basically have an interview at scale with a patient. So it allows you to ask an open-ended question to say to a patient, tell me a little bit about your care at the hospital. And the patient can respond in a paragraph. Hey, I love my doctors, I love my nurses, didn't so much like the food, et cetera, et cetera, et cetera. What did you love about your nurses and doctors? What didn't you like about the food? Well, I love that my nurse spent time with me. Where did they spend time with you? When in the process? That you could have that natural language type of conversation in that sort of application. And I think that to me is where we really need to go, is a place that recognizes the holistic experience of a patient rather than just questions around a specific part of a patient's care in an episode of care. So in general, how do you improve patient experience? So I'm going to give you 2 answers to that question. The first is a long answer, and the second is a shorter answer. It's just a very clear tactic that you could take home right now and start to use at your hospitals tomorrow if you'd like to. So the first is kind of the larger answer. When we think of patient experience often, we kind of go to the tactical things that we expect clinicians to do in patient experience. This is things like, you've probably heard of it, rounding, AIDIT, bedside shift report, tactics like that. That's kind of that yellow piece of the puzzle. But really, to make patient experience work well, you have to also align leadership development, employee selection, creating a service culture across the organization that everybody understands the expectations when it comes to treating patients, and then the technology to allow patients to feel connected throughout the course of that entire experience. I wanted to share a couple of anecdotes around this that really shaped my thinking about how we need to look more broadly at patient experience rather than seeing it as a bundle of things to do, but instead as really a way to connect people closer to the work that they might be kind of numb to at this point. So I was really fortunate. I got to have a day-long seminar with the former CEO of Ritz-Carlton North America. His name was Simon Cooper, is Simon Cooper. Really interesting guy. He looks like he just stepped foot off of his yacht. That's just his look. He's got the pop collar and the boat shoes and the slick back hair. And he gave this 8-hour seminar. And I, been studying the Ritz-Carlton as someone who's interested in patient experience, customer experience. And so we had a break in the middle for lunch, and I sat next to him. And at the time, I was running urgent care centers, and we were working really hard on patient experience. And I asked him, I said, what's the one thing that you would do, like right now, in order to improve patient experience at the urgent care centers that I'm at? And he looks at me without missing a beat. He goes, do you have an employee dining room? I was like, at an urgent care center? Like, we don't have a dining room. Like, I don't know what you're talking about. And he goes, well, you need an employee dining room. And I was like, why? Like, tell me about that. And he said, so do you think at the Ritz-Carlton, like, our housekeepers make more than at the Holiday Inn? It's like, they don't. They're all paid the same. The Ritz-Carlton is often in a part of town that takes 2 buses or, a long drive for people who are making, minimum wage to get to. So why do they come and work at the Ritz-Carlton? And they've done a lot of work around this, a lot of study around this. And he said that they answered him that this is the only place in the whole world where I get respect. I get home and, my kids are getting at me and my spouse is getting at me. But when I come to work, I get to sit and I get to have a meal, and the person having a meal next to me is the manager of this, 5-star luxury hotel. And the person over is the president of North America for this large luxury hotel. So that's why I stay, is because I'm treated really well when I'm here. Further, if you look at the way the Ritz-Carlton has sustained their performance, won 2 Malcolm Baldrige Awards, and elevate their care, it's a lot having to do with empowerment. But really, their fastest way between 2 points is they just hire people who are predisposed to give good care anyway, and then share the special sauce around the way Ritz-Carlton does things after that. So, that's why a service culture and an HR strategy that tries to get people that are not only technically proficient, clinically proficient, but also have the personality that they're predisposed to give good care anyway. Those people that are holding the door for you when you go through here, or are offering to help you if you're in a tough spot. Those are the folks that are needed to really drive patient experience results. So that's kind of the long story. The short story is, for HCAP specifically, there's a practice that I worked on and put in place at Robert Wood Johnson University Hospital, and I'll show you the results in a second, that really had a profound impact. And I think it achieved sort of a walk the walk around that inside out versus outside in perspective, and shifting to an outside in perspective. And it has to do with leadership rounding. So we borrowed part of this practice and augmented it from UCLA Health, which for years was in the 99th percentile in HCAHPS overall rating. So what we did was after our senior leadership meeting every week, we went to a conference room and were assigned different units across the hospital. We were a large academic medical center. So we had 34 adult units, 5 pediatric units, 26 ORs, large hospital. And then what we did was we went out in groups and rounded both on staff and on patients. And then after the rounding was complete, then we went back into the conference room and problem solved around things that we heard from patients and caregivers after that. The first time that we did it, there was a unit that was very high performing. They were in the 90th percentile for nurse communication, cardiac step-down unit. And we went there the first time. We were with the CEO of the region who was interested in doing this. And the first patient that we went to was a gentleman who was like, I'm so happy to see you, right? You know, he's used to seeing everybody in a white coat. We walked in our suits. So I'm so happy to see you. I've been here for a week and I have no idea why I'm here. And sitting next to him was his wife, and his wife was in tears. And he said, you know, I really shouldn't even be here. My brother-in-law, my wife's brother, is actually at a hospital across the state and he's not doing well. I should be with him and I'm sitting here and I have no idea what's going on. And so immediately we were able to jump into action. We went and we found his particular physician, and it turned out that he was not eligible for the procedure that he said that they told him that he was going to have, but nobody had given him that news. So we were able to huddle quickly in the unit, get him what he needed, the explanation that he needed, have the doctor come and explain to him that he wasn't eligible for the first procedure, but he was eligible for a second procedure if he'd like to do it. 2 days later, he had the procedure. 3 days after that, he was discharged. So it was rapid response that way, able to be done very quickly and efficiently. From there, you can see our results over the first few months of implementation of the new rounding. We measured very closely these 4 HCAHPS domains, and this is month to month overall. I was recruited to lead this startup, which James were called WHATA, by the way. But I was recruited to lead the startup and left in April. But one of the things that was interesting, or in May, but one of the things that was interesting was the hospital actually had a 5-month-long nursing strike shortly after this. And I was talking to some of the folks at the hospital, and I said, hey, it's great that the nursing strike's over. You know, how'd it go? And they said, well, from a quality perspective, we dipped. But from a patient experience perspective, we actually improved slightly over the course of it. I said, well, what do you attribute that to? And they said, oh, it was definitely the rounding. We did this every week, every Tuesday for an hour afterwards. It was definitely that. So these scores continue to rise and then sustain. You can see from the 18th percentile in January to an aggregate score of the 39th percentile with close to 1,200 surveys in as a result of that. So, you know, we talk a lot about rounding. I think rounding helps. I think it's a big ask to a lot of folks around the hospital. But I can tell you, I've seen it myself personally. If you do it in a really intentional way and with other leaders like yourselves, it can make a big impact on HCAHPS scores, which, as I shared earlier, our state really needs to do. In closing, if I could, I wanted to share one last story with you. So my parents actually, I think, are the only people in the world where you can say this about them. So my parents had a Jewish wedding in a Catholic hospital on Christmas Day. I think they're the only people you could say that. And the reason why was my grandmother, unfortunately, was terminally ill with cancer. She recognized a lump in her breast, and it was very late stage by the time that she was able to do it. My mother was the oldest of 3, the only one who my grandmother saw get married. And it happened in a hospital room. And, you know, I think about that a lot when I hear clinicians say I didn't have time for patient experience. And when I hear kind of the point of view that patient experience is something we do when things are good. It's something we do when we have time. It's something we do when we have resources. It's something that we pay attention to when we're trying to get QBR incentive dollars. But the truth is, you know, for my grandmother, modern medicine at the time could do nothing for her. So I always felt like, and I'm not clinical by background, but I always felt like that wedding was a part of her care plan. That it was critical to her. It did more for her than any of the drugs they were giving her to make her more comfortable. That being present at my parents' wedding was really the only thing she wanted at the time. So in the absence of modern Western medicine being able to save her, this to me was part of her care plan. And I get the sense that in hospitals across our state, even right now, there are patients who are experiencing the same thing. That something that they need in their care plan to feel fulfilled and cared for is actually something clinical, but also a lot more than that, addressing their needs at a deeper level. So I've seen that firsthand, talked to my parents about it firsthand, and know how much it meant to my grandmother. So patient experience matters. It's more than just the HCAP survey. The HCAP survey has ways that you can work on it and things that it doesn't cover. But I think focusing on patient experience is worth it because it's a way that patients can really tell whether or not they're receiving care in a way that they can trust and feel good about it. So thank you so much for listening today, and I'm happy to take any questions you might have.
All right, we gotta have questions now.
Okay. Thank you. That was an excellent presentation. I guess one question as somebody who helps form the QBR policy is there something you would do in the next year to change how we incentivize patient experience? And then, you were talking about AI and other things. Is there something that we should be starting to plan for, in a few years or 10 years? Because I think that's the more important conversation. But, we are lucky here in Maryland to be able to modify our incentives. So, any thoughts on something you would do in the near term would be great.
Yeah, and thanks for the question. I have to say the QBR policy, like I said, is very progressive and very strong compared to the value-based purchasing program. I think a couple of things. I think the attainment score is really important, and how you emphasize that is important as well. But the improvement component, I think, is something that hospitals need to be able to see and taste that they can actually achieve. And I think the second way of doing that is really through leveraging both, leveraging access as much as possible. I'm not sure what the right convener of this is, whether it's the HSCRC or the MHA or even CRISP, but there's so many indications in the data, like I had shared, about what to do to meet the needs of very specific patient communities and patient demographics. And for the most part, nobody looks at them. I mean, it's this, I think HCAPS data in general is this treasure trove of information that we don't leverage. If there was a way that HSCRC as a convener could bring together all of the data from all the different systems, and there's a lot of tools out there to analyze that data in a really simple way, those themes can emerge, which can make the state perform better. So then the second component of that would be, how do you create the incentives for hospital systems to pay attention to those results that you see? But that's what I would share. I think getting everybody's HCAPS data and all of their comments, that's even more important. And being able to share that and share it transparently, I think would make a big difference in the short term. In the longer term, I do think there needs to be a whole renewed view of what the HCAPS survey actually is trying to accomplish and whether it accomplishes those things. And if not, to figure out some methodology. I personally think using AI is the right way to go, to actually let patients tell you what they want to see more of, rather than us just asking them what we're curious about.
Hi, thanks for your talk. My name is Janine Danko. I'm at Luminous Health, and I'm the VP for Quality and Patient Safety. So patient experience is something that I'm thinking about all the time. I have two questions. One is just based on a comment, and I wanted to get your perspectives, but I think when we look at our HCAP scores, it's really hard to know if a patient that came in through our ER and made it on a med-surg floor and got discharged to home, like which part of their journey influenced them the most to answer the survey in that way, right? And so we all have issues with ED length of stay, but it's just like we only have so much time to be focusing on new initiatives. Do we spend more time on focusing on the ER experience, or so we're focusing on improvements in the units where we're getting the most responses from our patients that end up filling out the surveys? But I was just wondering from your perspectives, they're like, there's no easy way to tease out that data, right? But like you talked about the patient journey map, right?
Yeah.
It's I think it's just a conundrum for us because we want to do it all, but at the end of the day, we only have so many resources. And just the second question, you talked about using AI, but in your experience, maybe in talking to patients, are there certain technologies that health systems should be investing in whether it's in the hospital room, just more technologies to help patients understand what's going on with their care, or, digital whiteboards, or, again, better call system buttons, or, I don't know, I'm just curious.
Yeah, I mean, the reason why I'm at this company is because of the second question. We can talk afterwards. This isn't going to be like a pitch or anything, but I would share that. I think what's critical is the involvement of the advocates and caregivers around the patient and what technology they need to stay informed. I actually think, in what I've seen, that's far more critical to the patient's well-being than trying to explain to a patient who's, sick and on some kind of, medication, what exactly is going on with them. And I think that's one of the things where we've been mistaken in the past, just as an industry, is we focus so much on the patient, which is great, but the people who are shaping the experience largely are the patient's family members, and whether they're informed or how good that they feel about the care. I also think I mentioned, the themes that I saw was, do you feel like you have a good relationship with your doc? Do you feel like you have a good relationship with your nurse? Do you feel like they're coordinating with each other? Technology that advances those will also help to improve. On your ED question, just quick question back to you. Do you do the yes/no report? Do you have like an ED yes/no report in your data? Okay, perfect. So that's a good place to start. The other point of view that I've always had is, so like when I started the patient experience department, we were pretty lean, and I'm sure everybody's operating really lean. So my point of view was the hospital is the world's largest focus group. That's the way I saw it. So I made a priority to speak to a patient every single day and to round every day. And so I would focus my rounding on that question to try to get at that and try to get enough people so that I would have that. So I would say, did you come in through the ED? And they'd say, yes. I'd say, tell me a little bit about your experience in the ED. And then they would talk about where it broke down for them. So is it scientific? No. But is it more valuable than nothing? Yes. So if you can create like a short questionnaire, even something informal, that you can go around and use the patients who are getting care overnight right now, as that focus group, I think it will give you some of the answers to what's a low-hanging fruit problem that you could solve. Sure. And thanks for the work that you do.
Great presentation. Really appreciated the information. HFMA often has articles that indicate a strong correlation between the billing and automation there on these surveys. What's your take on that? Because what they say is sometimes everything could have been great, but if the billing is messed up, do you think that is an area where there should be a ton of focus? Or, because you were talking about the doctors and the nurses and all of that, and there are limited resources.
Yeah, great question. So absolutely, I've seen this everywhere I've been, that billing is a big issue, especially, what I guess the media would call surprise billing, for patients who are navigating, again, a confusing system, and they get several things. They get an EOB, this is not a bill. They're confused by that, they get their bill afterwards. It's a big piece, like I had mentioned, and this is something that where it shows up on the HCAP survey is in overall rating, or likelihood to recommend, sometimes discharge information, but more of those two areas. And I think it's a big area of opportunity, that sort of post-care part of the journey where patients can have a better experience. I do think when it comes to billing, there's a point where you reach diminishing returns on your investment in billing. I think training the folks who take those questions to be patient, attentive, and to go through things really specifically and deliberately is important. But there is a population of patients who are simply not going to have a good experience because of their insurance and their bill. And there's not an easy way to get around that. I think the answer is you're not going to satisfy everybody all the time. I'll tell you like my epiphany moment around this. When I was leading the urgent care operations for Adventist, we had a negative online review, and I lived by online reviews because it's a retail shop essentially. Like our competition was like the Verizon store, not at the hospital down the road. I didn't see it that way. And we had this negative review on Yelp, which every single one killed me. And the review said, the urgent care facility smelled too clean. And I was like, I can live with that. I'm okay with that. We're going to get some negative ones. So, right now with our performance as a state, we have about 30% of our patients who walk away pretty disappointed in one thing or another. when it comes to billing, I think we need to treat everybody with respect and reach kind of minimum service standards that everybody abides by. But there are going to be some people you can't please. And the good news is that that's the case nationally, and that gets factored in just through the size of the data set.
Other questions? This may be a question for our next coffee chat, but how, you talked about AI in terms of a survey mechanism, but what about, like, couldn't we use that today to analyze some of those comments that you're saying are so critical? And is that a tool that the hospitals and the HSCRC and others need to be thinking about, whether it's, you know, ChatGPT or, you know, whatever Google's version of it or whatever?
Yeah, great question. So I guess it was about 7 years ago, there was a company that started doing work in this. They're called Narrative DX. Anybody, just raise your hand if you're familiar at all with Narrative DX. If you're a Press Ganey customer, Press Ganey acquired Narrative, Press Ganey likes to acquire things. They acquired Narrative DX, and basically what Narrative DX does, James, is exactly what you just said. So it takes all of the patient comments and then groups them by the relevant part of where that comment pertains to the HCAP survey. That's how we solve the cleanliness question, the story that I was talking about earlier, and that uses AI and natural language processing to categorize those comments. The flaw in that, and where there's data strategy involved in that, is a lot of times hospitals opt to get the minimum amount of required HCAP surveys, and when that happens, you have relatively few comments. So you don't really have a significant pool enough of comments to draw from in order to aggregate it. But it's an application where both at Adventist and at RWJ, we used Narrative DX to figure out where the best place was and the lowest hanging fruit was from an HCAP standpoint to do that, and that's all AI and natural language processing. You didn't ask this, but I'll share this as well. I also am a big advocate that there are certain applications where technology should not be used to improve patient experience or to think that you improve patient experience. I was having a conversation with a hospital leader a few years ago, and he said, you know, we're not going to have patient transporters in 3 years. So why not? Well, because of auto-driving technology from Tesla, we're just going to install that in a hospital beds, and you know, the patients are going to be, we're going to push a button and they're going to navigate themselves around the hospital. And I was just like, all right, a few things, you know, hold my beer. The first thing is I drive a Tesla and that's scary. The second thing is, you know, patients are often the most scared before they go into surgery. Like they are freaking out, and you're gonna have them like all by themselves floating in nowhere. You know, that patient transport person is as much therapist as they are a transporter, you know, like that's not gonna work. And then the second thing, and all of my compliance and risk folks would be really proud of me, is like the liability around that. I mean, a patient decides, you know, halfway there, I'm not doing the surgery and hops out and falls. That's not good either. So I'm a big advocate of applying technology in the right places. I think when it comes to surveys and data analytics, this is what AI is made for. When it comes to some of the personal touch aspects of medicine, I don't think AI is going to have a real application moving forward. That's just my perspective.
Thank you very much.
Thanks.
Our next two speakers, William Henderson is the Principal Deputy Director at the HSCRC. He's the Director of the Center for Medical Economics and Data Analytics, where he focuses on working with the other centers within the HSCRC to manage and understand the data collected by the HSCRC and the results of the model. He's joined today by Krista Spiker, who joined the HSCRC in the December of 2023, so very, very recently, as the Deputy Director to lead their value-based programs. Krista comes from Mathematica, where she worked on policy development and evaluations for the state and federal clients. So please welcome William and Krista.
Thank you for that introduction. I assume I just push the arrow? Yeah, okay. So good afternoon. This is my first HFMA workshop. I'm really excited to be here presenting with William on all the great work we're doing on EQUIP and CTIs. Some of what I'll be talking about is a little bit dry, and I know it's later in the afternoon, but I promise that William will make it riveting when he talks about the results from the program. So my background and experience has really been primarily working at CMS and CMMI and now HSCRC in value-based care and value-based payment programs. And As many of you know, value-based care is really about holding providers accountable for improving patient outcomes, giving them flexibility to deliver the right care at the right time while reducing costs. And so what we're talking about today are EQUIP and CTIs. And EQUIP is the Episode Quality Improvement Program, and CTI is the Care Transformation Initiative. So when you hear those acronyms, you know what we're talking about. And those two value-based payment programs are really, EQUIP is really a physician-focused program, and CTI is a really hospital-focused program. So when I talk about those programs, we talk about those programs, just know that those are within that context, and I'll talk a little bit more about that. And at the end of the session, I think we hope you'll be able to understand, the current results for EQUIP and CTIs, and really kind of understanding where we're evolving and continuing to support the goals of the larger model. So EQUIP began in 2022, is a voluntary episodic incentive payment program for specialist physicians. There are 4 key features that I'll emphasize during today's presentation. First, again, this is a physician-focused program. Physicians will own and monitor their performance in this program. Second, EQUIP was designed to have upside-only risk with DIS savings accountability. And since this is the first program of its kind, it was designed to be very attractive to join and allow physicians to kind of get familiarized with this type of program. And we hope to reduce, a lot of administrative burden, and et cetera, et cetera. So, and EQUIP was also designed to be aligned with Care First episode payment program, and has a similar design and approach to reduce administrative burden, again, across different programs physicians are participating in across the state. And finally, EQUIP gives participants the opportunity to take part in the Advanced Alternative Payment Model, where physicians can become eligible for the 5% bonus if quality and savings targets are met. And the underlying methodology we are using to define episodes in EQUIP will be through the Prometheus episode grouper, which I'll go into more detail later in the presentation. So when it comes to value-based payments, the EQUIP program is a bundle payment program, as I mentioned. And across the nation, as many of you know, bundle payments have proven to be effective to help control costs and improve quality. By succeeding, physicians really help the state meet the savings targets and reduce potentially avoidable utilization, which we all know is incredibly important. And there are 3 primary elements of the EQUIP program. 1, each physician agrees to an episodic-based payment and enrolls in the program. Using a baseline period, the costs for that episode would be calculated to identify an appropriate target price, and that target price would then be used to assess performance. Performance year costs are compared to the set target price to identify if savings were achieved, and participants are then eligible for incentives. The idea really, again, is to have a very straightforward, not super complicated program so that physicians can monitor their performance and track their success in the program. In EQUIP, there are 4 main roles. The CRP entity, which pays the incentive payments to the EQUIP entities, and they sign a care partner arrangement with all of the care partners. Next is the EQUIP entity, which can be an individual care partner or multiple care partners, and performance is evaluated at the EQUIP entity level, and the EQUIP entity receives the payments. So a care partner, which is the specialist physician, triggers the actual episodes and performs the interventions. They sign a care partner arrangement with the CRP entity and receive normal fee-for-service and a potential incentive payment with the EQUIP entity. And they are also eligible to achieve the QPP status and the bonuses associated. And finally, HSCRC and CRISP calculate the episodes, monitor performance, determine incentive payments. We do a lot, maintain reporting, and they facilitate enrollment into the program. And also CRISP provides learning system supports to program participants as part in their learning collaboratives, and they also work with MedKai to provide that learning system support. We'll talk a little bit about that, more about that. So here we have, on this slide are the PY3 Prometheus episodes of care. I think I lost a footnote, but emergency department and musculoskeletal disorder episodes are non-Prometheus episodes of care, so they're not included in the Prometheus grouper. I'm not going to go through these, but this gives you a sense of the breadth of the program. So for PY3, the enrollment, we had 116 EQUIP entities enrolled in the program with a total of 3,209 and 3 care partners, and that is representing 41 specialties. Our smallest entity had 1 care partner and the largest 293. And on the right, you'll see the clinical episode categories and the number of equipped entities enrolled in each, with orthopedics having the largest number of entities at 25 and dermatology with 3. With that, I'll pass it to William.
Thanks, Krista. So Krista's promised this is going to be exciting. I think I won't fulfill that, but what happened in year 1? So first, just to clarify years, year 3 is actually 2024, so that's what we're in right now. So this slide has a kind of significant bust in that year 1 is actually 2022, so not 2021. So we're going back in time and talking about the first year because it's the year we have full results from. Year 2 is the year that just finished, and we'll be looking at results in that in the next few months. And then year 3 is ongoing now. So in year 1, which was much smaller than the numbers that Krista put up there, Equip accounted for about $400 million in costs. So that's about 4% of the total Medicare spend. So not a ton as a share. On the other hand, if you look at some of the CMS programs, it's actually gigantic compared to some of what those cover, considering the base we have, and we expect that 4% to go up as we get into future years, so we're actually pretty pleased with that as a starting point. It will never be close to 100% because there's a bunch of spending that just isn't suitable for this kind of program, but we do hope to see that continue to build. On that $400 million, we saved about 20 million, so about 5% savings. Most of the CMS research on these programs says that there's going to be savings in the 3 to 5% range, so that 5% was right in there. That 5% only counts savings if an entity achieved a minimum savings rate of 3%. So basically we said if we can't get to 3, we can't differentiate that savings from random volatility, so we don't give you any credit. Once you're over 3, we credit you from the first dollar, but that's excluded when we calculate that 5%. So that is people who achieve the savings. It was fairly concentrated, so there was about 50 equip entities in the first year. 19 of those actually achieved savings. So less than half, which is also not a total surprise. What we found generally, and I'll go into that in more detail in the next slide, is that the smaller entities struggled for a couple of reasons, and we'll talk about that. So based on that savings of $20 million, we paid out $13 million in incentive payments to physicians, so that's about 60% of the savings. It's a shared savings model, so a physician can get between 50 and 80% of the savings. Basically, if you start lower cost, you can get a higher share of the savings. The idea being that if a physician has already made good decisions and is already managing care efficiently, if they make further progress, they should get to share a greater share. If you're a higher cost physician to begin with, you only get 50-50 of the savings. So, and in general, it sort of averaged out to the middle there, that the typical savings was about 60%. So that was kind of what we expected. And clearly, $13 million being paid out in incentives to 19 groups was a significant bump to those. I think the largest check was right around $2 million, which is, is a significant payment. So this slide is our one exciting analytical slide, which is really what I do, so we have to include these slides. So each dot on this slide is an equipped entity. The horizontal axis is the number of episodes. The vertical axis is the percent savings. And the sort of pale yellow box you can just about see, that speaks to where we see there was really savings. And so if you look at most of the entities in that size, you'll see I think there's a distinct bias towards positive savings. And that reflects mostly the larger entities. And that's one of the reasons we think the savings here were real, that once we got up to those larger entities where you get statistical significance, most of them managed to drive savings, except for that one dot that's like 1,500 entities at negative 20%. We don't show what they did, but they really had work hard to create that kind of negative outcome. Because frankly, if you do nothing, you should be on the 0 line, right? So I don't know how you get yourself to negative 20. What is not as successful is if you look at all the blue dots closer to the vertical axis, right, they're kind of distributed randomly around 0, and that's the smaller practices, and we generally found the smaller practices struggled to drive savings. We have a couple of theories on that. One is just the statistical noise. They could be doing an awesome job, but if they had 2 cases that happened to have severe complications, that could destroy their savings. The other is that when we look at the practices that were successful, they did a lot of stuff. So the dot that's at the far right there, that's right on 6,000, they actually had way more episodes than that, but I didn't want to extend the graph. It kind of distorts things. They are incredibly annoying, I will tell you. We work with them all the time. They're incredibly annoying. I think they're pretty proud of that. But I think what that meant is they were really intensely focused on how they can succeed in this program, what they needed to do. They could probably give you this presentation better than I can because they know the program inside and out. And I think that really is a difference, that those groups with that kind of scale who decide to commit can bring the resources, can hire the analysts, can whip their physicians into line, and then they have the scale in order for the outcomes to really show up. So going forward, we're going to focus a little bit on how we can support those smaller practices. We don't want to, only work with large practices, right? We want the small practices successful, so we're looking at some program elements for them. This slide is a separate way of carving out those savings. So this slide breaks it into the three specialty areas. The first year one, really at these three specialty areas is expanded. That list Krista showed you is where year 3 is. It's vastly expanded. And what you can see here, right, is that most of the savings were in the orthopedics. So the orthopedics in total were about 6%. Gastro was actually slightly negative, and cardiology was right on 0. But even within that, you'll see there's a fair amount of variation in individual episodes. So like pacemaker defibrillator within cardiac was relatively successful. And then with orthopedics, knee and hips were pretty successful. Lumbar spine fusion. This wasn't totally surprising. Those orthopedic episodes are pretty well proven to be amenable to this kind of program. There's very clear things the physicians can do. Site of service shifting was a big factor here. And then you see that with the cardiologist, right? Pacemaker defibrillator is sort of the closest thing to a procedure episode like knees and hips, and so you see more success there. Where physicians were less successful was like something like AMI, where it's more of an acute condition and there's an awful lot more variables up in play, and it's a lot harder to plan for. But I think we're hoping that over time, practices will begin to refine their approaches and be able to find savings on those. But one of the philosophies of this program is we, the HSCRC, did not want to decide on limited clinical areas of focus. So our intent over time is basically if any type of physician would like to play, we will set up an episode for them. We needed to build the program, so we started with 3 areas where we knew we would have high interest, but we continue to do that. In year 3, we're debuting a program focused around managing musculoskeletal conditions. So rather than just looking at, if I have a knee replacement, how well can I do? We're trying to focus more on upstream, right? Maybe how can we avert people needing knee replacements or hip replacements because they get better treatment initially. So that program we developed in conjunction with some Maryland physicians and built the episode specific to that because we had a strong interest in that. So that's one of the things we're trying to do is really make sure if we have an interested party who wants to do an episode, we will try and be responsive to that. It's up to them whether they can drive savings ultimately, right? We're going to set up the framework. If they can't drive savings, they can't drive savings. So I think with that, I'm going to.
Okay, so I told you he would make it fun. So I think the next, we want to talk a little bit about Prometheus. As I mentioned earlier, Prometheus is the episode grouper we've been using since program inception. And while it aligns with the Care First episode program and includes 97 episodes across a variety of clinical areas, the methodology is a bit of a black box. And that's a concern for a lot of the folks that are involved in the program. And given that episode development has also stalled, we are left having to create any new episodes outside of that 97 that are currently available. So this contract ends in December, and we're currently in discussions around a transition to a different grouper called PACES, and talk a little bit about that. So PACES, the Patient-Centered Episodes of Care System, these are just some, there we go. Just some kind of background bullets on PACES. But we are currently assessing we're currently assessing this grouper that offers open source episode definitions, and the methodology and logic is available, and it isn't the black box we have with Prometheus. So that is very attractive to HSCRC, to CRISP, and to the participants in the programs. And so we hope to make a decision very soon after a series of meetings with specialists to compare and ensure continuity to the extent possible in a transition from Prometheus to PACES. There's a lot on this slide. So, what are the next steps for EQUIP? What's next? CRISP's Learning Collaborative has an evaluation underway, and together with MedChi, they're hosting learning collaboratives, as I mentioned earlier, really highlighting the practices that are earning those incentives. Year one results, as William noted, were favorable and absolutely exceeded expectations. And the savings, again, as William noted, exceeded CMMI's bundled payment programs and other national programs. So we consider this a success. And in years 2 and 3, the program continues to grow and has already substantially expanded. 25 new episodes in year 2 and 5 more in year 3. So we expect to have around 4,000 participants in year 3, 2 times the size of year 1. So it's growing very quickly. And again, as William mentioned, there's a lot of interest in assisting these smaller practices that are struggling a little bit to perform. MedChi, who's our strong partner, has been assisting these smaller practices and grouping together these practices into single entities. And in year 4, we hope to provide practices with further support to identify and deploy interventions that will make them successful in the program. Okay, so switching gears a little bit to CTIs. So let's orient a little bit here. Since early in the all-payer model, the HSCRC has attempted to create various alignment programs. This is before my time, but these were meant to encourage hospitals to partner with non-hospital providers to reduce the total cost of care. And apparently, we were not very successful for various reasons. I think, as noted here on the slide, there was a disconnect between the programs we created and the hospital's clinical efforts. Hospitals had to earn substantial savings before they received a reward, and as we know, it is costly for hospitals to manage the total cost of care effectively. And so the return on investment in the program was really uncertain, and we had to figure out, the HSCRC at that time had to figure out a different approach. Hence, CTIs were developed and allow hospitals to define their own populations to focus on, providing all hospitals with first dollar savings and distributing savings in a net neutral manner. So hospitals that do not participate or make successful efforts in care transformation are actually penalized. And this is a little dry, so bear with me, but in CTIs we have thematic areas which share a common attribution methodology and parameters whereby hospitals select their populations. Currently, there are 5 thematic areas: care transitions, palliative care, primary care, geographic, and ED care. An example is in the care transitions thematic area. Bennies are attributed to the hospital where they were discharged from, and then they limit the population based on certain DRGs, chronic conditions, number of prior hospitalizations, and so forth. And similar to EQUIP, CTIs have a target price that is based on the total cost of care of the Bennies attributed to the CTI in the baseline period. And those baseline costs are updated for inflation and risk adjusted. We compare hospitals to their own historical performance, so it's an improvement-only program. We can also set baseline periods as far back as 2017 to recognize those early adopters. And so hospitals earn savings if their performance period costs are less than the target price. They can earn 100% of the savings they achieve that exceed the minimum savings rate, or MSR, which ensures that all payments are made for savings that are statistically significant. And all the shared saving payments are offset on a statewide basis, so that means that hospitals that are less successful in the CTI will pay for the savings of those hospitals that were successful in the CTI. So it's important because Medicare continues to benefit from care transformation, and hospitals which are not engaged in successful care transformation pay their fair share of meeting the statewide savings target. And then the last slide is really, so when calculating the final savings amount and offsets, only positive savings are considered to be counted as savings. They must meet the minimum savings threshold, or MSR, as I mentioned. And just a little bit about the MSR is hospital specific and depends on the nature of the CTI and the total volume of the episode. Hospitals are assigned separate MSRs for episode and panel-based CTIs. This is getting in the weeds a little bit, but multiple similar CTIs can be combined to attain a lower MSR, and if MSR is met, all savings are credited from first dollar. So total savings are aggregated, and each hospital gets their hospital-specific savings minus their share of the CTI statewide savings offset. With that, I will hand it off to William to say funny things again.
All right, I made Krista do the hard part of describing the calculation. So we do all that math, and this is the outcome we get. So across the state, and here we are talking about the first year of the CTI program, which was fiscal year 2022. And hospital savings ranged from -3 to +7% of spending, generated about 130 million of total savings. And then we do this redistribution exercise, as Krista noted, because the savings are paid for by other hospitals. So that 130 million actually translated in 56 million of revenue moving between hospitals. The reason that number is much lower, right, is some of the offset is by the hospitals that were successful, so they just get less payment. But in some cases, you do have hospitals who were unsuccessful, moving revenue to hospitals who were successful, and that's that 56 million. So that was kind of the overall outcome. That was the fiscal 22. The fiscal 23 program, there's a 6-month run-out window for episodes and then 3 months of claims run-out. So we will just be wrapping up results for the fiscal 23 program with March claims. And then we'll be updating this presentation. So, but right now we're looking back to the first year. So one of the things we were asked to do is, okay, so we had some winners and losers there in that +7 to -3 range. What things drove programs' success from a point of view of analyzing the outcomes, right? One of the things we didn't do is we did not ask hospitals to exhaustively catalog all their interventions because we were trying to keep the administrative burden low. And we think that kind of cataloging is always a bit fuzzy because frankly, the devil's in the detail, right? 5 hospitals can write, well, I enhanced my discharge planning program by adding an additional social worker, and, and it all depends on how well you do that, right? Not so much as what you actually do. So we didn't focus a lot on the sort of the underlying programs. We were just trying to look at it. If we look at the outcomes and across the criteria, like the size of the hospital, the baseline year, the CTI criteria, what drove success versus not success. And in general, what we found is it wasn't driven by the CTI definition. So 2 hospitals that focused on the same populations, a care transitions initiative for people with a diabetes comorbidity. Some of them were successful, some of them were unsuccessful. We didn't find broad patterns in the definitional and success. So that sort of leads us to, it is in fact those operational things. So what did you do for those people with diabetes comorbidity? We didn't necessarily collect that information. That's sort of where we hope the Learning Collaborative will help to get people there. There were some lessons learned, and this, I'm going to go through some data here, but these are kind of, I think, the big 3. Frankly, the primary care-based CTEIs were pretty successful, partly because they just get a lot of dollars, right? So you don't have to do that well to generate big positive outcomes, right? If you can achieve 1% savings on a huge bucket, you're going to more likely to meet a minimum savings rate because the statistical validity is larger. But on the other hand, and it's going to translate into more money than hitting a 10% save on a tiny population. And because the primary care tend to be broadly defined, they tend to do well. Simpler definitions are better, and I'm going to talk more about that in the next slide. We did see a small pattern that when we looked at how, okay, I'm going to focus on care transitions on discharge, and then I'm going to narrow that down. We did find some pattern that when you narrow that down, focusing on high utilizers and specific chronic conditions was more successful. Some other strategies, and I've got a slide on that, so we'll come back to that. This is just an overview. As Krista said, there was this 5 thematic areas. Care transitions was the largest in terms of number of CTI, although I think primary care is the largest in terms of total dollars. And in the second from right column, that's the % exceeding MSR, right? So 50-50 win rate, sort of, when you look at creating statistically significant savings. And then you can see the % saves ranged from 1.6 up to 3.2. So that gives you a sense of how people did, and that's within those broad categories, right? Within care transitions or within palliative care, hospitals could focus things differently. So that's not to say all 55 care transitions were identical, but they were all within that thematic area, which really speaks to how people get what happens after discharge. So this slide goes into the point about simpler is better. So what this table shows you is the number of criteria that they were layered into that care transitions thematic area, right? So what 0 means is basically somebody looked at everybody who discharged from the hospital. One criteria means it was everybody who discharged, and I then limited it by their chronic condition. Two means I limited it maybe by their chronic condition and the number of prior visits, and so on. And what you generally see is that while that winning percentage, the second from column right, there's not a particular pattern to that, like what percentage actually was successful. What you do see is the savings as a percent of MPA dollars, so how significant were my savings versus my overall spend. There is a distinct line there, right? The more criteria you add, the less percentage you get. And the simple explanation for that, right, is you get more dollars. If you have less criteria, you're narrowing your population less. And so it means your intervention is presumably hitting a much larger set of people, so it's easier to generate more significant savings. And I think our message to that would be do small things, or maybe large things, but do simple things, do simple things and do them well, right? It's better to focus on doing X really well for everybody you discharge than it is to focus on doing X, Y, Z, AA, and AB for these 10 people, because even if you hit a home run on those 10 people, it's not going to be that material in terms of dollars. So that's the thing that I think we took as our conclusion and passed back is simplify the definitions, simplify the interventions, but focus on doing those high-value interventions as well as you can. The other question was, well, is there certain ways of narrowing the population that make more sense and that generate better outcomes? So I mentioned chronic conditions, geographic service area. You know, I think the ratio here is the key column, I should say, on the right. That's the percent of CTIs with savings that use that criteria. You can see that, you know, they don't vary that much, but it does look like the chronic conditions one is high. Prior hospital use, so those are your high utilizers, those are people you've seen multiple times. Those are more likely to be successful. Geographic service area means where you're focusing it on discharges from a certain geographic area. Is also fairly successful. I don't know that that's a particularly strong pattern here, and I'd probably focus my prior statement about no matter which of these you focus on, figure out what the hard-hitting interventions are and do those for as many people as possible. Next steps on the CTI, we're possibly going to add a new CTI for what is really year 4, which is the year that will start on July 1st, that will focus around outpatient surgery or other outpatient care. Right now, all the CTIs are focused primarily around either inpatient or primary care. So we're looking to add a CTI there. We expect to be analyzing the results on year 2 within the next few months. We've now approved a risk cap. So in year 1, if you lost, you could lose an unlimited amount of money. In practice, the largest loser lost 3%. Going forward, there's actually going to be a cap at 2.5%. And we were trying to create some certainty for the industry around, okay, how badly can this go for me? The worst I can do is 2.5%. And then we'll be starting year 4 enrollment in the next couple of months, I think. Yeah, that's it. So we'll pause, and I'm going to sit down and make Krista answer all the questions.
What do you guys have?
Up here.
Thank you for that presentation. Quick question. You made reference to, for CTI program in year 2, there's going to be a maximum risk cap at some percentage. In theory, I guess, when we think about the CTI program in general, it's largely revenue neutral through the MPA program. So the savings generated are paid for by the other hospitals. If the paid for by the other hospitals reaches 2.5%, those hospitals are capped. So does that mean the other hospitals absorb more of the loss, or do you also have cap on the winnings side as well? Because if you cap only the losses, how do you achieve revenue neutrality unless those that didn't hit the 2.5% cap actually absorb a bigger portion because of the cap being hit? Does that make sense? What my question is?
And the way we go around that is the 2.5 cap only applies before the application of the cap itself. So you can actually lose more than 2.5, because if you hit the cap, you're then going to have to pay your share of the piece that you've avoided. So that's how it gets back to revenue neutrality is you could cap to 2.5. Let's say that shaves off $1 million. We then spread that $1 million across everyone. So that person who was capped at 2.5 is actually at like 2.5 plus their share of the $1 million. Yep.
Other questions?
All right, guys, thank you very much. All right. Our last speaker of the day, Megan Renfrew, is the Deputy Director of Policy and Consumer Protection for the HSCRC. Megan analyzes legislation, drafts regulations, and leads staff in the implementation of all new legislation. Megan also directs the HSCRC's policy development related to hospital consumer finance protection. Prior to joining the state of Maryland, Megan actually worked for the CMMI or CMS Medicaid 1115 demonstrations and the collection of Medicaid enrollment data. So please welcome Megan.
Good afternoon, everyone. I am lucky enough to be the very last person, so I'm going to apologize for that right away. It's wonderful to be here again. It was great to be here last year. It's good to see you all. Originally it was planned that my colleague Deb Rivkin would be joining me today. She's not able to be here today. I'm going to be talking about the legislative session, which is ongoing right now, and she is our person in Annapolis, and she's physically in Annapolis today. So also it's just me. So I am going to talk about legislation today, and the first thing I wanted to ask, I know this is a room full of finance folks, and so could you raise your hand if you're involved in the legislative session in some way? That might be going to Annapolis to testify or meet with legislators. It might be providing input on legislation for the entity you work for. So if you could just let me know, it'll help me give a sense. I like that Alan raised his hand. Okay, that's helpful. Thank you. All right, so I'm going to start my presentation with an overview of the legislative session. Maryland's a little different than the federal government, so I'll talk about that, a timeline of the legislative session, and then I'm going to review some of the healthcare bills that have been introduced this session, so you can have a sense of what's in the pot. We don't know what's going to come out of the pot yet. And finally, I will give you an update on a couple of the laws that we've been working on implementing over the past couple of years, just so you know where we're at. And then I should leave time for questions, or you can all leave. But I'm very happy to answer questions. All right. So the goal of the legislative session is to turn ideas into bills and then bills into law. Ideally, those ideas should solve a real-world problem and solve it in a way that doesn't have a lot of unintended consequences. I suspect that each one of us has some opinions on how often we accomplish that goal. All of us, I think, have seen unintended consequences of laws from time to time, or laws that don't solve the problem they were intended to solve. We also see that. So I am going to spend a little bit of time talking about the process. I think most of us learned about the federal process when we were in high school or college. Some of you may remember the Schoolhouse Rock video. If you're of my generation, if you're quite a bit younger, you might have missed it. So in Maryland, we're a little bit different. So like Congress, we have two chambers. We have a House and a Senate. And to start the whole process, a legislator will take an idea. It may be their own idea. It may be an idea they got from one of your lobbyists, or an idea they got from a constituent or a community organization. And they will go to a legislative drafter. These are nonpartisan staff that work for the legislature who will draft that into a bill. And then they do what's called introducing the bill. And introducing the bill means they bring it into the House that they belong to. So I'm going to use the House of Delegates through this whole example. So a delegate will bring it to the House of Delegates, put the bill in a box. That's like an old school inbox. In theory, I've never actually seen this, but it's the best way to theorize what's happening. And that constitutes introducing the bill. The bill then gets referred to a committee. There's committees of jurisdiction. You could think of them like committees of your board right? And they review all the bills that are in their topics areas. For us, generally in the healthcare field, we work with the House Health and Government Operations Committee, and then in the Senate with the Finance Committee. And so they hold a bill hearing. That is the biggest opportunity that the public has to influence the process after a bill's been introduced. That is the time when people submit written testimony, letters about what their opinion on the bill is, and or sit at the table in front of the committee and explain what they think should happen with the bill. In some of the committees, particularly on the House side, they have subcommittees. So after the bill hearing at the committee level, a subcommittee will meet, and that's more like a working meeting where they work out what needs to be tweaked on the bill, and then it goes back to the committee for a vote. Once the committee has voted, so we're in the, let me show you where we are. So we're in the middle box on the top. Once the committee has voted, they take the bill back to the floor. So when you think about, if you picture what a legislature looks like, that room where all their desks are and there's somebody sitting up on the dais. And the committee tells the whole House of Delegates what they think should happen. So do they think it should be approved or not approved? Then they have debate, and then that House votes. And in Maryland, this is where our process is different, one of the ways. Maryland, they vote twice. The first time they vote on the floor, it's called second reader, and then except at the very end when things get kind of, things speed up, they vote again in 2 days, just to make sure that they feel the same way they did 2 days ago. So that's called third reader. And after it passes the House of Delegates for third reader, it does what we call crossing over, which means the bill is sent to the Senate, where they repeat the whole process. We have referral to committee, in this case Senate Finance. Senate Finance holds a hearing, another opportunity for public input, 2 votes on the floor. So now we've gone through the second line here. This is where my slide falls down, because I wrote my talking points after my slide, and so I'm going to apologize for that. When we get to the point that the Senate is done with this bill, we could have a couple of outcomes. So one is that they voted to approve a bill that was exactly the same as what passed out of the House of Delegates. There were no changes, in which case the bill gets sent to the governor. Or they might have amended the bill, in which case the bill gets sent back to the House of Delegates, and the House of Delegates can decide to accept those amendments and say, your Senate version is good, cool. And then they vote on it and it goes to the governor. The third option is for the House to say, nope, those amendments are not great, we won't take the Senate bill. So either the Senate, you have to take back your amendments, or we have to have a conference committee, which is essentially like a negotiating committee. Where it has 3 members from each house, and they have to get together and figure out a deal. I'm going to pause here at this step of the process before I get to the governor. Throughout my description so far, I've talked about a bill that starts in the House of Delegates, goes through the House of Delegates, and then goes through the Senate. The same process is happening for bills that start in the Senate. They go through the Senate first, and then they go through the House of Delegates. So there's this parallel process in both houses going on. I used to have a slide that looked like that, and it confused people. I'm not sure this was better. Give me feedback on that. What I think is important to know is that the bill can die at any point in this process, right? Maybe there's an idea that somebody had that they want to have it become a bill, but they never find a delegate or a senator to sponsor it. So it never even gets introduced. Or maybe the bill didn't get out of committee, or maybe it was voted down in either house, or maybe the conference committee doesn't reach agreement in time. Or maybe it just doesn't make it. I'm going to talk about timing in Maryland, but we have a 90-day legislative session. It is a sprint, not a marathon. I've talked to other states where they have 6-month sessions, they have all this time. Sometimes things just don't make it across the finish line through no reason that has to do, like it doesn't have to do with the quality of the bill, they just run out of time. And so all those reasons, all those times when a bill can fail is why you all have government relations folks and lobbyists and MHA. Right? All those folks, their job is to help mitigate those risks and prevent something from failing just because it doesn't make it over the finish line, and help smooth the road so that it keeps going at full speed. All right, so now I'm going to turn to the bottom box, the governor. So once the bills go to the governor, those that pass, the governor has 3 choices here in Maryland. And this varies from state to state too. So if you're a government geek like me, like that's a fun thing. Like what's the rule in various states? So here, he has 3 choices. He can sign the bill, and then it becomes law. Or he can take no action on the bill, and it becomes law over a certain period of time. So for bills that pass late in the legislative session, he has 30 days to take action, and if he doesn't take action in those 30 days, it automatically becomes law. And then the third option is to veto the bill. This is very rare, particularly rare when right now we have both houses of the General Assembly controlled by the same party as the governor. They're generally going to have worked things out before it ever gets to the point of a veto. It's just not going to get there. So we did see vetoes under the prior governor, particularly at things that had to do with raising taxes. So that is my little mini lecture on legislative process. We're going to move on. So I did talk about the session being extraordinarily quick. It starts on the second Wednesday in January. That's in our Constitution. And it ends 90 days later. There are some key dates for those of us who work in this field. The governor's budget bill is introduced in January. Why is that important? The bill often contains funding for hospitals. The University of Maryland system particularly benefits here. But that's also where MHA's grant program shows up for capital projects. So that's all contained in the budget bill. There is a deadline this week for when bills have to be introduced, which means for a member of my staff who's here today, he's having a very busy week because he has to review every single thing that gets introduced and figure out if we want to track it or not. So that's a very busy week for us. And then bills are expected to cross over. So if you remember back, they're go from the first row to the second row in my last slide by mid-March. And if they don't do it, what that means is they're probably moving too slowly to make it to the end. And then the last day of the session is in early April. For your government affairs colleagues, this month and next are going to be their busiest months of their year. We essentially run on the same schedule as tax preparers. This is the hardest part of our work year. So now I'm going to turn to bills and focus on some bills that have been introduced. I'm going to do this in categorized into themes that I think are going to be interesting to you. I will say some of these are bills that HSCRC doesn't follow that closely. They're more relevant to you as industry than it is to us as regulator, which may limit me on answering questions, but I'm going to do my best. I do have a couple of notes of caution as I move on to these next slides. The slides do not have a complete list of health-related bills. I both because that's a lot, but secondly, because I put them together last week, and this week is the busy week, and so we just didn't know they existed when I put the slides together last week. Information changes daily. I tried my best to get caught up today so I could speak intelligently, but it is changing all the time. I think those are the main cautions. So the categories I'm going to talk about. One is workforce. I know that's crucial to all of your businesses. The second is healthcare treatment and healthcare quality. I know we just had a really excellent presentation on healthcare quality, so I'll talk about that. Behavioral health and substance use disorder is a huge focus every year, I think, but this is definitely one of them. I'm going to talk about health insurance a little bit, and then there's a miscellaneous category where a few things here and there that I think you would be interested in. On workforce, there are a number of bills this year that are about allowing licensed professionals to work in multiple states, either through reciprocal licensure or through compacts where Maryland would accept another state's license and the other state would accept our license. The purpose there is to allow more flexibility for workforce across state lines. It's particularly helpful in telehealth, right? Because then somebody can do telehealth with a Maryland license in another state in the compact. We are also seeing some bills that, and I'm hoping I'm using this term right, again, not my area of expertise, but have to do a little bit with scope of practice. So there's a couple of bills about expanding who can give certain vaccines. There's one on pharmacists and there's one on emergency medical technicians. And then there's a bill about changing the level of supervision for physician assistants. So they go from a delegated agreement to a collaboration agreement. There's also a bill to raise how much Medicaid pays for long-term care services. The purpose of this is to increase wages in that space. We know some of the hospitals in this room have trouble discharging to long-term care because there's not enough capacity. Maybe if there's higher wages, they could keep their workforce a little more easily. There's also at least one bill focused on supporting education for the next generation of nurses. I actually think there's two. There's a loan repayment one and then one about community colleges. On healthcare treatment and quality, we see a number of bills that seek to regulate the services that are delivered to patients. There's a bill requiring hospitals and urgent care centers to have protocols to detect and treat sepsis. My understanding is that most of you do this already, so I don't know that it would be a big change in how you do business. Another bill requires hospitals to educate patients about safe sleep before an infant is discharged from the hospital. And there is also a Safe Sleep for Infants bill that requires hospitals to be certified by the Cribs for Kids National Safe Sleep Hospital Certification Program. We also now have two bills related to ED wait time task forces, so we're going to be keeping an eye on those and see where they go. On behavioral health, we're seeing a collection of bills about coverage of treatment by Medicaid alone or Medicaid and health insurers. For example, there's a bill that would require Medicaid and state regulated insurers to pay for an annual behavioral health wellness exam. There's another bill that would require coverage of naloxone, the drug for opioid overdose recovery, and would cap the consumer cost share. There's also a bill that changes what insurers need to report to the Maryland Insurance Administration about their compliance with the federal mental health parity law, which essentially says their coverage should be similar between mental health and somatic care. And there's a bill related to certificates of need for psychiatric services. There's also a bill from the governor that seeks to change emergency evaluation and involuntary admissions procedures and increase access to assisted outpatient treatment programs. It's a priority for the governor's office. I think many of us who are thinking about where folks are discharged to and if there's sufficient capacity can certainly understand why a bill related to increasing access to outpatient treatment might be useful. All right, this is the miscellaneous slide, and I'm also going to talk about some miscellaneous things that are not on this slide. So we, for the things that are on the slide, we do now have 2 bills related to financial assistance. One would allow hospitals to sell medical debt to government entities that are seeking to forgive that debt. Some of you may have heard about RIP Medical Debt, which is a nonprofit that works nationally to do this. Every once in a while, a celebrity will do that. New York recently did a big initiative, or Connecticut, for mixing up my states. But so this would allow that to happen here. Another would prevent hospitals from using asset tests or their service area to limit their financial assistance eligibility. There's also a bill on Maryland's Prescription Drug Affordability Board, which works to control drug costs in Maryland. They're looking at upper payment limits on drugs. There is a bill to potentially increase the trauma fund using taxes from firearm sales. There are 2 bills from the Attorney General's office that are relevant. One is on expanding facility fee notices. So I think many of you may know we require facility fee notices for patients in the clinic rate center. This looks to expand it beyond the clinic rate center. And the Attorney General has introduced a bill related to notice of out-of-network care. And then in the truly miscellaneous category, there is a bill about making sure patients have access to a telephone. All right, and so then I'm going to talk briefly about health insurance. Every year, we see bills that seek to add mandates to coverage of what health insurers need to include in their benefit packages. We're seeing that again this year. I've already talked about some of those in the behavioral health space. Outside of the behavioral health space, we see a bill that seeks to mandate coverage of obesity treatment under Medicaid, another that seeks to limit cost sharing for labor and delivery for commercially insured parents, another one that relates to coverage for hearing aids. We also have at least one bill this year that's focused on limiting insurer use of utilization review and prior authorization. That might sound like wonderful news to some of you. And then there are bills that are seeking to increase access and affordability of health insurance. One of those is the Access to Care Act, which has a hearing tomorrow, which would let immigrants who currently are not allowed to buy insurance through the Maryland Health Benefit Exchange or Maryland Connection, to do so. They'd have to buy it at full price. There wouldn't be any subsidies, but it would allow that purchase to occur. There's another bill that relates to the current young adult subsidy program in the exchange, so that helps make sure that the insurance price for young adults is lower. So they're very price sensitive. They're a healthy population, and so it matters that we try to keep that price low so they can afford to buy coverage. And is there anything else I have up there? Some restrictions on canceling individual benefit plans. So that was my last slide on legislation. I did want to spend just a couple of minutes on an update on laws that have passed in the past few years. When I was here last year, I gave you an update on changes to Maryland's hospital financial assistance and medical debt laws. We've seen legislative changes in that area every year since 2020, and as I just said, we expect more. One of the major changes was a requirement that hospitals offer income-based payment plans. We still have not finalized those regulations, so I just wanted to let you know, yes, we are still waiting on that. MHA is very dutiful about asking me about that status every 2 weeks. I will be sure to provide MHA with an update when I have it. I absolutely commit to that, but right now we're just in a holding pattern. We have also been working for the last 2 years on the hospital reimbursement law. So this is seeking to reimburse patients eligible for free care who got care between 2017 and 2021, who paid a bill. In December, we shared a draft memorandum of understanding and data sharing agreement and scope of work with the hospitals for review. That feedback's due tomorrow. I've already seen hospitals sending me feedback, and if you haven't had time to do that, even a high-level couple of sentence email helps me. So if you've gone deep into detail, super helpful. But anything I can get that gives a sense of where you are is helpful to me. And the impact, and because we've been getting some really good input, we've got a couple of hospital members on our work groups on that bill, and they've helped us identify issues that we, I think, on our own as state agencies wouldn't have known were there. So I just want to make very clear, I really appreciate that feedback. And that's it. My contact information's here. You can reach me at any time. External affairs is part of my job. And I'm also very happy to take questions.
That was wonderful, Megan.
Sir. Yeah, Megan, wonderful job. Appreciate it. From growing up outside of Maryland, I appreciated the little chart. So thank you very much.
You're welcome.
Has anyone been brave enough this session to stand up on anything on malpractice, or are they just too afraid that's going to get cut off?
I have not seen a malpractice bill. I think I would have flagged it. You may want to direct that to MHA. I know there was work happening with the president's office the Senate president's office this past year, and I don't know where that is. It is not an area we are deeply involved in, so I'm not up on where the politics are there.
Hello,
Wayne?
Megan. 2 questions about process. Some of the bills you showed had 2 numbers, a House bill and a Senate bill.
Yep.
Does that mean it's crossed over, or they were introduced to both chambers?
They introduced the bills in both chambers, and I actually meant to say something about that. Yeah, so there's a copy of the bill that got introduced in the House and another one that got introduced in the Senate. It's another thing that's kind of unique to Maryland. I think of this as having 2 horses in a race instead of just one. Generally, if they're gonna make the finish line, they both make it, but it does up your chances that one of them is gonna make it.
And then the last question I have is, you had mentioned the governor's budget and the timing of that as it impacts this process. But I understand that the governor also would like legislation passed
Yeah.
from time to time. So does he have to go through one of the chambers?
Yeah.
Or does he, okay,
Mhm.
that's what I was.
Generally, I'm going to back that up and then get to the answer to your question. As state agencies, we start developing our legislative priorities essentially as soon as the legislative session ends. We start thinking about what comes next for the next year. And we have to tell the governor's office what we want to do by September. And then the governor's office has their own priorities, right? They have things they want to accomplish. The governor's office can either tell us we can't move forward, they can do that, as a state agency, or they can say the bill is a departmental, meaning it's something that the department is a specific agency or department is pushing forward, those are generally introduced by the committee chairs for the committee of jurisdiction. Or they can call it an administrative bill. That is the governor's highest priorities. They do a press release on them. They do a press event. It's usually a short list. Those generally get introduced by the Speaker of the House or the President of the Senate. So that, it's showing that, like, respect. And that would be true even if they weren't of the same party. That is just a normal way that the process works and the respect they show each other for their respective roles.
Other questions? All right, thank you, Megan.
Thank you.